Just a brief introduction of mine. I passed out from IPH in 1997. Then I did my master's in musculoskeletal physiotherapy from University of Hertfordshire. Basically, my main USP is manual therapy, and that too in Mulligan's and neurodynamics. So I have been practicing, running my own clinics and working at Max Hospital as well. So this is the basic anatomy that we all have studied in our first year. So we all know spine is made up of vertebrae. On top of, actually there are 33 vertebrae, but 24 are mobile. This we all should know about what is the spinous process and where is the facet joints. So this is the basic structure of a vertebra. And for the most of the 2 days, we would be learning about this intervertebral disc and how to mobilize the facet joints. So disc is between the two vertebrae, body of two vertebrae, and there is a facet joint behind the disc. So what is the surface anatomy of the facet joint? It is 0.5 centimeter above and 1 centimeter lateral to the spinous process. This is the important thing that you can note yourself. So that would be useful for locating facet joints. Facet joints are 0.5 centimeter upward and 1 centimeter lateral to the spinous process. So if you are talking about the facet joint of C5, C6, so we have to locate the spinous process of C6. Then we move 1 centimeter lateral and 0.5 centimeter upward. Somewhere there would be the facet joint between C5, C6. These are the different stages of disc herniation. Physiotherapy usually works till degeneration and prolapse. In some cases of exclusion also, I have worked. But in sequestration, most of the cases would require surgery. The central part we all know is nucleus and the outer margin is hard. So these are the properties of the curves of vertebral column. They give strength, they maintain balance, they absorb shock during walking and running, and they protect the spinal column from fracture. Another important thing that we need to remember is facet joint alignment from top to bottom. So what is alignment in the cervical region with regard to the gravity? Can anyone answer in the chat box, or maybe if Dr. Niranjan can unmute students? Anyone can answer? What is the alignment of facet joint in the cervical area?
Towards the eyeball.
That is the direction of the mobilization that we do. But what is the alignment of the facet joint in the cervical area with regard to the surface, with regard to the earth's surface? So if you are standing upright and on the cervical region, the facet joint alignment is parallel to the ground. And as we go down from cervical till lumbar areas, the alignment of the facet joints goes from parallel to perpendicular, and it is sharp perpendicular at L4, L5, L5, S1 to the ground. So our direction of mobilization changes with the vertebra that we are mobilizing on, and it is towards the eyeball, that rightly said. Our direction of mobilization in Mulligan's mobilization, it is always towards the eyeball. So in upper cervical area, it is parallel to the ground. As we go down, we have to incline the direction, and at the lumbar area, it is perpendicular to the ground. These are the basic anatomy that we know. Cervical spine made up of 7, thoracic 12, and lumbar 5. This we need to remember that the spinous process of C2 is bifid. So when you palpate the spinous process of C2, this is used in headaches and vertigo. You would be palpating on the two bony surfaces of the spinous process, and there is no spinous process of C1. Everybody would be knowing that. Okay, how do we locate spinous process of C7? This is the useful surface anatomy for us. So whenever you bend your neck, the most prominent spinous process, that is of C7. So from the C7, if you go down 1.5 centimeter down, so you can calculate each and every spinous process. It is roughly 1.5, somewhere it is 1 centimeter, depending upon the stature of the patient, structure of the patient. I think I don't need to discuss all these things. Okay, in the thoracic spine, the unusual thing is that we have ribs also there. So in the thoracic spine, if we have a problem of facet joint stiffness, we need to mobilize ribs as well. I would be showing that in the practical sessions, how we mobilize ribs, intercostal spaces, and how we mobilize sternum. Dr. Niranjan, can you keep a note of that so that you can remind me later on the day?
Sure, sir. Sure, sir. No issues.
Okay, so we would be mobilizing the ribs because the thoracic spine is attached to each other vertebrae and to the ribs as well. So if the patient is having problem in deep breathing, so ribs mobilization is very useful technique. And we all know that when we have a gluteus medius weakness, when we have a sciatic scoliosis, diaphragm gets shrunk. So in that cases also ribs mobilization comes to help. Okay, we need to know the alignment of the ribs with the vertebra and with the sternum slightly inclined. It's not directly parallel to the ground. As you can see, the structure of the rib from the front, it goes down and it joins at the back in. It is not directly parallel to the ground. So you have to keep that in the mind while mobilizing the ribs. I would be showing you the techniques on Wednesday. Another important joint is sacroiliac joint. Joint, but that is the most need shock absorbing. So if SI joint gets stiff, we can get back pain and we can get other problems as well. So many of us overlook SI joint, but it is one of the most important joint to mobilize. So we need to understand the alignment of sacrum with the ilium and how we mobilize it. I would show you on Wednesday. And lastly, we have coccyx bone. The clinical importance is coccyalgia. So during our on the coccyalgia patient, but we can do the mobilization of the coccyx, which gives a better relief to the patient. Palpation of the spine is important, so that we get our hands on the right vertebra. So we can start with the C7 spinous process, as I have already told you, and we can start with the scapula also, inferior angle, which is at T7, superior angle at T2. These are the different surface anatomy. All of you must be knowing that. Okay, so now I am moving to the next PPT. So these are the basic. I would be telling you the basic principles of manual therapy right now. If one of you is not able to hear me, or I'm not audible to any one of you, please do raise an alarm or please do inform, because these are the basics of manual therapy that we should all know. Just to brief about the history of manual therapy, James T-Rex is considered to be the father of modern orthopedic medicine. Okay, he was mainly known for his works on this to be the all sorts of back pain. To start techniques. Most of the other work works are based on his theory. On has contributed a lot to manual therapy, convex concave theory, and how do bones move when we do the exercise. This is the basic thing that we do in manual therapy, convex concave rule. I would be discussing just in a short while. We all know Trimal Siemens, who gave a theory of tight bands, soft tissue mobilization, trigger points. Now, this Maitland is the Bible of manual therapy. Most of you are first year MPT, so every one of you must be aware about Maitland, PP IVMs, PA IVMs. And the Mulligans updated on the works of Maitland. Okay, now coming to the definitions. These are the basics definitions that we must be knowing. The motion of joint surfaces concave gives same as osteokinematic motion. Convex gives opposite of osteokinematic motion. And the osteokinematics is motion of the bone, that is abduction, or refers to the humeral motion when addressing the shoulder. The basic definition of mobilization is passive movement using arthro and osteokinetic principles to increase the mobility of joints. Okay, how we grade the motion of the joints? 0 is ankylosed, 1 is gross restriction. So as you increase the number, there is increase of the motion. So 6 we consider as very unstable. So for the unstable and hypermobile joints, we don't do manual therapy. In the hypermobile joints, we don't do manual therapy. What we do brace, or maybe in the most unstable cases, we would require surgery. There's another concepts of close pack position and loose pack position. So whenever we start with the manual therapy of a patient, we keep the joint in a loose packed position. What is this position? This is the position. Any position other than the close pack position is considered to be loose packed position. What is close pack? It is the position. It is the extreme of one of the most habitual motions of a joint. It is the position in which the concave surface is in complete congruence with the larger convex surface. The capsular ligaments are under maximal tension. The joint is minimally distracted when a traction force is applied. Joint rotation will cause closed pack position. So we don't do manual therapy in the closed pack position. So we all must be aware about the closed pack position of different joints. And these are the end-field types. Whenever we are examining any joints, we need to ascertain what kind of end field we are having. So capsular end field is stretching, ligamentous is similar to capsule, but it is still harder. Soft is painless compression of soft tissues. Hard is bone to bone. So in the end field of hard, we don't do grade 4 mobilization. Spastic is palpable muscular resistance to stretch. Springy is loose body blockage. Empty is patient stops motion before resistance is felt. So in the empty kind of end field, we need to be very careful. We start with grade 1 manual therapy. Joint capsule, we all know what is the joint capsule. Now this is important. Treatment plane. What is a treatment plane? It lies on the concave articulating surface. Concave means D-shaped or C-shaped. Concave and convex is C-shaped. Sorry, concave. Concave is when the body is shrinking, and convex is when the body is expanding. It lies on the concave articulating surface perpendicular to a line from the center of the convex articulating surface. So in this joint, this is the convex articulating surface. Are you able to see my cursor? Everyone?
Yes, sir.
This is convex and this is concave. So a perpendicular line from the center of the convex to the concave surface. This is the treatment plane. It moves when the concave surface moves. And it remains essentially still when the convex surface moves. So by this we can draw the concave convex rule. See, just to repeat it again, it moves when the concave surface moves. This is the concave surface and this is the convex surface. And it remains essentially still when the convex surface moves. So if this surface is moving, so our treatment plane would be still. And when the concave surface is moving, our treatment plane would be moving. So when our concave surface is moving, let's say in knee joint, when our tibia is moving, so we have to give in the same direction as the movement of tibia bone, because our treatment plane is moving. And the opposite with the concave, with the convex surface. In the shoulder joint, when our humerus is moving, we have to give in the opposite direction. We have to do manual therapy in the opposite direction. Have I made myself clear?
Yes, sir.
Okay, just to repeat it again, this is our convex surface and this is concave surface. So in knee joint, because our tibia surface is concave, our tibia surface is concave, we have to give gliding in the same direction as the movement of the bone. And in the convex surface, as in humerus, in shoulder, we have to give gliding in the opposite direction of the opposite to the direction of the movement of bone. So when there is a concave on convex, it is the same direction. When there is convex on concave, it is opposite direction. Now I will be discussing Maitland mobilization and the gradings of oscillations. So articulations are graded oscillations used to restore joint play, component motion or range of motion in a hypomobile joint. The extent of accessory movement from beginning to end of range. Are all of you aware about the gradings of mobilization?
Yes, sir.
So we know grade 1 is gentle small amplitude oscillations in the beginning of the range. Grade 2 is larger amplitude, painless in the painless range. Grade 3 is a larger amplitude but in the at the end of the range. And grade 4 is the thirst at the end of the range. Grade 5 is thirst after the physiological limit. So most of the physiotherapists are not using the grade 5 gliding. Grade 1 is used when the sin level is high. And as we improve on the sin level, sin is severity, irritability, and nature of the pain. So when we have a patient who is having a severe pain and acute stage, we would be mobilizing in the grade 1 range. And as the condition improves, we can opt for grade 2 and grade 3. And when in chronic stage, or let's say when the pain is minimum and there is only stiffness left, we can opt for grade 4 mobilization. Just to repeat, grade 1 is small amplitude movement at the start of resistance, gentle oscillations used for pain relief. Grade 2 is large amplitude movement. It can occupy any part of the range that is free of any stiffness or spasm. It never reaches into resistance, always resistance-free movements. So the grade 3 is large amplitude movement to midpoint of resistance. Move from R1 to halfway between R1 and R2. And as I said, grade 4 is small amplitude movement to the midpoint of resistance. This is the oscillatory movement, often stretching into stiffness or spasm. We use grade 4 when there is minimum of pain and most of the stiffness is there and the pain has eased out. Grade 5 is small amplitude, high velocity thrust at the end of motion. So we do it at the end of the physiological ROM. These are the basic features of application of mobilization forces. Movements are oscillations within the range. If the oscillations are too fast or too slow, it will be impossible to gain any feel of the movement. So whenever we do the manual mobilization, our fingers and our thumbs, these are the eyes. We would be feeling the movement of the joint of the movement. So whenever there is a bony end feel, we should stop the mobilization. We should not give thrust techniques when we achieve the bony end feel. The whole body of the physiotherapy should be used to generate the movement, not just the small muscles of the hands and fingers. That too, because it would tire you out if you are using just your hands and fingers. So whenever you are giving the PA glides, posterior anterior glides of the spinous process of the vertebra, so you have to glide from your shoulder. The gliding is directly perpendicular to the ground surface. Patient is prone and you are giving gliding from your shoulder, and your thumb or maybe the pisiform bone is just feeling the spinous process, and the force for the manual therapy is coming from the shoulder. It's not from the wrist or the forearm. Have I made myself clear? This is important point that you should all be knowing.
Yes, sir.
Yes, sir.
Maximum movement will be produced when the joint to be mobilized is in the mid position for all other movements. So it is a loose back position. The therapist's hands must be relaxed so the feeling can be maximized. Pressure and force should be sufficient to the grade. This comes with practice. So as we all be doing practice on Wednesday, we should be able to judge how much force we have to apply for grade 1, for grade 2 and grade 3 and grade 4 as well. Pain often limits the therapist's ability to mobilize in the appropriate direction. In these cases, it is desirable to continue in a pain-limited or pain-free range. So when the pain is the prominent symptom, we start with only grade 1 mobilization. And these are the direction of mobilization forces. Just give me half a minute, I'm just coming. So on the spinous process, what Maitland says, we have to give posterior anterior gliding in the perpendicular direction on the center part of the spinous process. So if you are not locating on the exact spinous process, what would you achieve? You would achieve the incorrect mobilization. Okay, so we have to mobilize on the central part of the spinous process. That's what I was mentioning. That C2 spinous process is bifid. So we have to take care of while we mobilize on the spinous process of C2. Afterwards, it is easy to locate the tip of the spinous process. Are you able to appreciate the direction of the glide?
Yes, sir.
If your gliding
Yes,
is inclined, that would be incorrect. That won't achieve the desired effects. There is a difference between Maitland and Mulligan's gliding. Maitland PA glide is directly perpendicular on the spinous process, whereas Mulligan gliding is towards the eyeball in the direction of facet plane. Mulligan's gliding is more practical. It is more achievable than the Maitland gliding. So in practice, I'm using only the Mulligan's manual therapy. Maitland is basically to examine the patient and to come to the level of the exact vertebra which we have to mobilize. But the desired effect we achieve only through the Mulligan's manual therapy, which is more practical, which is more facet joint friendly. These are the basic rules of mobilization. The patient and therapist both should be relaxed. We need to keep the procedure as pain-free as possible, stabilize and mobilize. The first session should be very brief. We don't want to achieve everything on the first day. We need to monitor reaction after a brief session of manual therapy, and we should compare to the normal side as well. So when we mobilize the right shoulder joint, we should be knowing what is the physiological range of motion in the left shoulder joint, and we should appreciate the accessory motion of the left shoulder joint before attempting to mobilize on the right shoulder joint. We don't mobilize acute, actively inflamed joints, but we can still go for grade 1 manual therapy. That is not strictly prohibited. But yes, if the pain is too high for the patient to tolerate any kind of touch, we would be using other therapies than manual therapy. But most of the cases, even even in acute cases, they can tolerate grade 1. They can tolerate the nags movement that I would be telling you on Wednesday. Nags are the Mulligan's mobilization. Contradictions to mobilization. Absolute means we don't touch that patient. So the malignancy involving the spine, cord equina, or spinal cord compression. What are the symptoms of spinal cord compression that we need to watch out for? Can anyone write on the chat box? What are the symptoms of spinal cord compression we should be aware about? Yes, loss of bowel and bladder control. What else? What else? As a physiotherapist, we must not stiffness, weakness. Yes, but what kind of weakness? Firstly, we need to look for foot drop. If there is a weakness of dorsiflexion, if DTRs are disturbed, So these are the symptoms of spinal cord compression. There can be cases where bowel and bladder is not disturbed, but there is a loss of dorsiflexion. So we need to be aware about spinal cord compression cases. Active inflammation or infective arthritis and rheumatoid arthritis, yes, because in rheumatoid arthritis there is a it's not only about the joint, it is basically physiology and the immune system which is getting worse, and the joint can be fragile, brittle, so we can rupture the joint and the capsule when we do the manual therapy. So we need to be very careful when doing rheumatoid arthritis patient. Fractures, we all know we can't mobilize, we need to give immobility to the joint. VBI, vertebral artery insufficiency. I would be telling you one manual for the vertebral artery insufficiency on Wednesday. Okay, the care we need to take is the presence of neurological deficit. What is the symptoms of neurological deficit? Read on the chat box. Yes, abnormal reflexes. The symptoms that was written by a student before on the, yes, neurological deficit is paresthesia, tingling sensation, numbness, sensory loss. Yes, sensory loss. This is one of the most apparent neurological deficit. Spondylolisthesis. What is spondylolisthesis? It is the anterior or posterior shift of one vertebra over another. So we need to be very careful not to harm the spinal cord when we mobilize spondylolisthesis cases. Hypermobility is movement more than the physiological limit, so it is already hypermobile. So we don't need to give more mobility. Okay, now we need to be aware about the severity of the patient. Severity refers to the intensity of symptoms and the extent that they limit normal. So before therapy, on a pain scale of 0 to 1, you can get the grading from the patient. So before manual therapy and after manual therapy, you get the grading of severity from the patient and you compare it. Irritability refers to the ease in which symptoms are produced and the time it takes to settle. Immediately on movement versus after sustained activities. You need to look if the symptoms goes away immediately or it persists for a couple of minutes after after the patient stops the comparable movement. So if a patient of low back pain he's having a problem, pain onset on bending, forward bending. So you ask the patient to forward bend, he gets the pain, and then you ask the patient to come to the normal position. If the pain gets eliminated immediately, that is a low irritable situation. If the patient stays there for 10-15 minutes, that is a high irritable position. Nature of the pain refers to the type and extent of injury. There can be different types that we should be aware about: aching, throbbing, burning, stabbing. The type of pain can give you an idea of what kind of pathology the patient is having. What are the comparable signs? These are the signs you compare before and after the manual therapy. So these comparable signs refers to the combination of pain, stiffness, and motor responses, which the examiner discovers on physical examination and considers to be comparable with patient symptoms as described in the subjective examination. So you ask the patient also about the symptoms before and after manual therapy, and you examine the patient as well before and after manual therapy. So you look for the comparable signs. To decide on the treatment techniques, we should take into account sin level, and then we test and retest. Then we choose one or two techniques and complement with specific home exercises. After you do the manual therapy, you can also give some kind of home exercises to the patient. That is all about the principles of manual therapy. So the first approach I would like to discuss is CDX manual therapy. CDX is one of the form of diagnostic and treatment based approach of manual therapy. It is both invasive. Invasive is infiltration technique, but we won't be discussing on the infiltration part. We would be only discussing the non-invasive technique. CDX method of diagnosis is mainly by selective tissue tension, which is basically application of specific amount of manually applied pressure on selective tissue, which is to be assessed and treated. He is James CDX. He was the one who coined orthopedic medicine term. He was based in London. He was an orthopedic surgeon, and he was the first to approach the study of soft tissue injuries in a systematic way. He laid down the foundation of a method of logical, clinically reasoned differential diagnosis, which he called selective tissue tension testing. These are the brief concepts of CDX method. All pain arises from a lesion, so we need to come to the source of the pain. So all treatment must reach the affected site. All treatment must exert a beneficial effect on the affected site. So what he said was, if you are treating only the pain, if your manual therapy is not affecting the basic principles of CDX concept is that all pain arises from a lesion, and our manual therapy should target that lesion. So we need to decide where is the lesion, what kind of lesion it is, and that would decide our manual therapy. We all should have a good understanding of the phenomena of referred pain, and the examination is by selective tissue tension test. What are the inert structures? Inert structures are non-contractile, like ligaments. And what are the contractile structures? Muscles. So how do we differentiate between the two? Whenever we are doing passive movement, if there is a pain, most likely that would be due to the inert structure problem. And when there is a contraction happening, it can be both passive and it can be ligament as well as muscles. So when we do the resisted isometric contraction, that would only contract the muscles. So we can isolate the muscles from the ligaments. We would be discussing about the transverse friction massage, traction, and manipulation. Inert structures are joint capsule, ligaments, fascia, bursa, dura mater, dural sheath, nerve roots. And the contractile structures are muscles and tendons. So when resisted movement resisted isometric movement is giving you pain, then the lesion is through the contractile structures. And when a passive movement is giving pain, then the most likely lesion would be through the inert structures. CDX hypothesized that most of the joint they have a particular capsular pattern. Each joint has its own distinctive capsular pattern associated with injury. The capsular pattern denotes inflammation due to injuries. A non-capsular pattern implies that the capsule is not involved and that intra or extra-articular tissue is the source of pain due to inflammation or injury. These are the brief capsular patterns of different joints. Shoulder, we all know in periarthritis, external rotation is most limited, then abduction, then flexion. Again, end feel, we should all have a feeling about the joint end feel, because that is very important for progressing our manual therapy. After every session of manual therapy, we should get a feeling of joint feel. This is the brief flowchart of tissue selective tissue tension testing. So firstly, you would be doing the passive movement. If that is painless, we rule out the inert structure. Then we do active movement. If that is painful, we do the isometric resisted movement, and then we selectively do the isometric contraction of different muscles. Then we can land upon which muscle is affected, what kind of lesion it is. These are the practical rules for doing passive movements. Therapist position must be such that there is no obstruction for the movement being carried out passively. Therapists can observe patient's expression while movement is being done. So you can judge the level of pain through through your hands. The hands are placed on the patient joints, so you can get a feeling of the movement that would give you the level of pain the patient is having and the expression of the patient. So you need to constantly observe if there is a change of expression on the patient, and if there is a change of end feel at the joint through your hand. If the joint has suddenly stopped moving, or the joint is having a springy kind of end feel, so that would decide on the future course of manual therapy. So there are two indications. First is the expression of the patient, and the other is the feeling of the joint that you are getting through your hand. If a muscle is tested, then the muscle should be tested in a relaxed position. If passive movements are painful, usually inert structures are at fault. Extra-articular limitation, two joint musculature tightness. In the ligament sprain, painful if torn. Ligament sprains are painful only in the grade 1 and grade 2 sprains. In the grade 3, when most of the ligament fibers have been torn, it gets painless. सबने सुना है? सुन लिया जो मैंने अभी बोला?
Yes, sir.
If most of the ligament fibers have been torn, it would be painless. So we need to be careful in the painless hypermobile joint. Muscular painful if torn, spasm, adhesions present. Internal derangement, loose bodies, degeneration. In the meniscal injuries, we do different kind of tests for diagnosis of meniscal injuries. So that is the example of internal derangement. For performing resisted movements, mid-range positioning of the joint, no movement at the joint while testing. It is isometric contraction. Muscles other than those being tested must not be induced. Patient must exert himself herself to the utmost. Examiner pays considerable attention to his position with respect to patient because he needs to keenly observe patient's expression. Patient expression sometimes can be misleading, so you need to observe through your hands also if the patient is exerting pressure or not, and if the patient is comfortable with resisted movement or not. And we need to always compare bilaterally. This is a good comparison. We need to compare it to the other side. If the resisted movements are strong and painless, this is normal. Strong and painful, this is a minor lesion or of some part of muscle. Weak and painless, this is the complete rupture. So we should be alerted whenever we have weak contraction and painless contraction. the patient is not having pain, but he is not able to contract it. The contraction is very weak. So we should be alert for this kind of observation. Weak and painful fracture or some kind of secondary deposits. Painful on repetitions. Let's say for first couple of resisted movement, the patient is not having pain, but on repetitions, the pain is there. So it would be intermittent claudication. All resisted movements painful. There is a gross lesion lying proximally, usually capsular. Interference with motor conduction will display as weakness on resisted movements. What is interference with motor conduction? Spinal cord compression or some kind of neurocompression, neuropraxia that would display as weakness on resisted movements. Interference with sensory conduction will show itself as cutaneous analgesia. Pressure on nerve roots, these usually refer segmentally. Compression of dura refers to pain extrasegmentally. I think we deep transverse friction massage. I would quickly go through this deep transverse friction massage because the time is short. We are already 4 o'clock. This transverse friction massage is applied by fingertips directly to the lesion in a transverse direction. Dosage is 20 minutes for 6 to 12 sessions alternatively. If a muscle is to be treated, then it must be placed in a relaxed position. मसल्स को कोई भी हमने मस्कुलर लीजन में अगर हमें डीप फ्रिक्शन देना है तो पहले हमें मसल्स को बिल्कुल रिलैक्स पोजीशन में देना है और उसके बाद हमें ट्रांसवर्स फ्रिक्शन मसाज देना है. If tendon without sheath must be treated, then it is placed in a most accessible point. जैसे हमें टेंडो एचिलिस को अगर देना है डीप फ्रिक्शन मसाज तो मोस्ट एक्सेसिबल कैसे होगा? पेशेंट को प्रोन कर दीजिए और फुट को बिल्कुल रिलैक्स, मतलब डॉर्सिफ्लेक्शन ना करते हुए मिड रेंज में रखेंगे तो टीए टेंडन आपका मोस्ट एक्सेसिबल हो जाएगा. So in that position you would be giving the transverse friction massage. For the tenosynovitis, tendons must be taut. Tendons tight होने चाहिए. Ligaments most palpable position. Treatment is applied by therapist fingertips. This is important. Hand and forearm should be in a straight line parallel to the movement plane with interferential joints slightly flexed. I would show you that on Wednesday. These are some of the principles for deep friction massage. No movement between finger and skin is allowed. The main goal of friction is to move fibers in relation to each other and adjacent structures. Amount of pressure would depend on the depth of lesion. So during examination, you have to decide on the depth of lesion. The age of lesion means if it is chronic or acute, and the tenderness of the lesion through the sin level. If the pain is high and if the pain is not a prominent feature. Pain can be avoided by starting with a minimal amount of pressure, just enough to reach the lesion. Duration is usually given for about 20 minutes and on every second day. So you give alternate day. Massage given on acute injuries should be very low intensity and short duration. Treatment is stopped once the patient is pain-free during daily activities and functional tests are totally negative. These you should be knowing it. Increase blood supply by moving the painful structures. It helps to free it from adhesions. The structures moved in the limitation of normal behavior but not stretched. Friction itself is a painful technique. Okay, this is important. Position of the patient must be comfortable and the lesion must be within fingers reach. So the therapist as well as the patient both should be comfortable, and the reach of the joint or the muscle on which the deep friction massage has to be done, that should be very accessible. The therapist should avoid flexed position. Movement is generated in the shoulder and conducted via elbow and forearm to the digits. So the force is not coming from the digits. The force is coming from the shoulder through elbow. So there are three types of movement in the deep friction massage, three techniques mainly: to and fro movements, pronation, supination, and pinch grip. On Wednesday, if time permits, I would show you the practical session on deep friction massage. Although this deep friction massage is not very clinically feasible, because if you're doing deep friction massage on all the patients, you won't be able to do it after a couple of patients because it is very tiring. Pronation supination technique is used where the lesion is difficult to reach. And the anterior aspect of the Achilles tendon is performed with the pulpy part of the third finger reinforced by the index finger. So your middle finger is being reinforced by the index finger, and then you do the supination and pronation of your arm. By that supination and pronation movement, there would be deep friction massage, and that is useful for the areas which is not very easily accessible. Pinch grip is grip of thumb and index finger and reinforced by the middle finger. By drawing the finger upward over the affected area, the therapist feels the muscle fibers escape from the grip until only skin and subcutaneous tissues remain. On the spinous process on the paravertebral muscles, we use the pulp of the thumb for flat surfaces, taut bands, nodules in flat surfaces. So mostly I use this technique on the paravertebral muscles. The effect of deep friction massage is better than steroids because effect is long term compared to steroid and doesn't interfere in healing process. So there is no side effect of deep friction massage, often used before and in conjunction with mobilization technique. So whenever you are trying to do grade 3 or grade 4 mobilization, so it is always good to perform the deep friction massage before attempting to do manual therapy. Effect is local, performed only at the site of inflammation. This gate control theory, this is the basic theory going behind this deep friction massage. These are the indications and contraindications we should be aware about. Indications are myosynovitis, tenosynovitis, tendinitis, adhesions, partial rupture, scar tissue. Contraindications are open wound, local metastasis. Metastasis is if there is a cancerous growth. Hematoma, extensive ossification in muscles. Myositis ossificans, ligaments of capsules, complete rupture, acute stages of tendinitis, tenosynovitis, or myosynovitis. So we should be careful about acute stages and subacute or chronic stages. We should be able to distinguish between different stages of tendinitis, tenosynovitis, and myosynovitis. For very enthusiastic physiotherapists, these are the studies behind this deep friction massage. So if you want to go deeper into this, you can go through this article. Now this is important that I wanted to discuss about traction. Traction is kind of manual therapy, but most of the physiotherapists are not exactly able to calculate how much force that we need to give to traction and which cases we need to rule out for traction. So I would be discussing on this traction. Separation of articular joint surfaces in order to create space between them can be used in conjunction with manipulation or as sole treatment by itself. The force we need to start on cervical spine is 15 lbs, increase to 25 lbs, never cross 50 lbs. In the lumbar area, it is 25% of the body weight up to 50% of body weight. We never cross more than 50% of body weight. And in what position we give traction? These are the positions. For the upper cervical, we give 0 to 5 degrees of flexion. From C2 to C5, we can increase the degree of flexion from 10 to 20 degrees. And then from C5 to C7, it is 25 to 30 degrees of flexion. Lumbar area, we can give 70 to 90 degree of hip flexion. That's why आपने पहले नोट किया होगा, हम स्कूल रखते थे पहले ट्रैक्शन देते हुए. So that was useful for giving hip flexion. At L3, L4, we need to give 75 to 90 degree of hip flexion. Then again, L4, L5, it is between 60 to 75, and then L5, S1, it is 45 degrees. So as you know, the lumbar spine is a curve, C-shaped curve. So that is why there is slight increase from L1 to L4 in the hip flexion, and then we start to decrease from L4 to S1. Because there is a curvature in lumbar spine. Are you able to get this point? Are most of you able to appreciate the point why we slowly increase till L4 and then we start to decrease the degree of hip flexion? Am I audible?
Yes, sir.
I want any one of you to please give me yes or no in between so that I don't feel like speaking to the walls. Or maybe you can drop a message on the chat that you are able to understand, and if there is any question, you can let me know. So you can see that from L1 to L4, there is an increase of hip flexion from 70 to 90 degrees. And then from L4 to S1, there is decrease in degree of hip flexion due to the nature of the curve at the lumbar spine. Am I clear? Okay. The effects of traction are, this is useful to distract joint, reduction of spinal disc protrusion. This gives soft tissue stretch and it relaxes the muscle. Clinical indications are spinal disc bulge or herniation, spinal nerve root impingement, joint hypomobility, and muscle spasm. But the degree of traction and the angle of traction would vary from case to case. This is the effect of traction on the disc. You can see there is a small bulge in this figure. Are you able to follow my cursor?
Yes, sir.
Yes, sir.
Okay. So in this figure, there is a small bulge of the disc, and after doing the traction, we can see the bulge is moving in. So what kind of tissue moves in? It is the nucleus which moves in. The annular part remains outside. the annular, which is hard material of the disc, it doesn't settle into its original position. It is only the nucleus material which we can move through traction. The contraindications are when motion is contraindicated, acute inflammation, joint hypomobility or instability, peripheralization of symptoms, uncontrolled hypertension, and this is the inverse traction. But in patients of hypertension, this is contraindicated. There is no as such machine over there. It is only the force of body which is giving traction to the spine. Force of the patient body. The gravity is playing role in giving traction to the spine. Now this is important. I want all of you to pay little attention over here.
Okay, sir.
The patient has come to you with a sciatic scoliosis, or even if there is no sciatic scoliosis, the patient says that he's having pain radiating down the right leg, and on the left side bending, the pain is increasing. So would you be giving traction to that patient?
Sir, repeat the question.
एक हमारे पास पेशेंट आया है, उसको राइट साइड में रेडिएशन है और उसको लेफ्ट साइड बेंडिंग में पेन बढ़ रहा है, इंक्रीज हो रहा है, और राइट साइड बेंडिंग में पेन रिलीफ हो रहा है. उसका रेडिएशन राइट साइड है. प्लीज राइट ऑन द चैट बॉक्स एवरीवन, आपका क्या आंसर होगा? I'm giving a scenario, a patient having a right side radiating pain. The pain is increasing on left side bending and relieving on right side bending. So would we be opting for traction on that patient? Okay, now I would explain you why we won't be giving traction to that patient. There is a concept of medial disc bulge and lateral disc bulge. Okay, see, this is our bulge. Are you able to follow my cursor?
Yes,
on the
sir.
first figure, this is the bulge, and the yellow small little thing, this is the nerve, and the yellow thick part, this is the spinal cord. So the bulge part is lateral to the nerve. When the bulge part is between the nerve and the spinal cord, then we don't give traction. When the bulge part of the disc is between the nerve and the spinal cord, this is medial disc bulge, and when we attempt to give traction, that would further compress the nerve. And the clinical finding of medial disc bulge is relieving same side flexion, aggravating opposite side flexion. Are you able to follow me?
Yes, sir.
So whenever we attempt on the manual therapy or traction, we need to decide if the disc bulge is medial or lateral. अगर पेशेंट राइट साइड रेडिएटिंग पेन में आया है और उसको राइट साइड बेंडिंग में दर्द कम होता है, तो इसका मतलब है कि मीडियल डिस्क बल्ज है, और उस कंडीशन में आप ट्रैक्शन नहीं देंगे. उसका लेफ्ट साइड बेंडिंग में बढ़ता है और राइट साइड बेंडिंग में रिलीफ होता है. तो इसका मतलब उसका मीडियल साइड बेंड है, तब ट्रैक्शन नहीं दोगे। जब डिस्क बल्ज लेटरल होगा तब आप ट्रैक्शन दोगे, उसमें फायदा होगा। उसका इंडिकेशन है कि सेम साइड बेंडिंग वुड एग्रीवेट and the opposite side bending would relieve the pain. Okay. Can most of you follow this point? Should I repeat it again?
Yes. Understand.
Yes, sir. Repeat.
हाँ जी। और देखो फर्स्ट फिगर में क्या है कि यहाँ पे लेटरल डिस्क बल्ज है। दिस इज द फर्स्ट फिगर। ओके, फर्स्ट फिगर में क्या है, पहले डिस्क बल्ज है, फिर नर्व है, फिर स्पाइनल कॉर्ड है। अगर यहाँ पे हम सेम साइड बेंड करेंगे, सेम साइड बेंड करने पर अगर पेन बढ़ता है और अपोजिट साइड बेंड करने पर पेन घटता है, तो वो लेटरल डिस्क बल्ज है, उसमें आप ट्रैक्शन देंगे। और अपोजिट होल्ड्स फॉर मीडियल डिस्क बल्ज। पेशेंट का राइट साइड पेन है और वो सियाटिक स्कोलियोसिस में लेफ्ट साइड है, उसका स्कोलियोटिक कर्व लेफ्ट साइड है, तो इसका मतलब उसका लेटरल डिस्क बल्ज है, उसमें आप ट्रैक्शन देंगे। एंड द अपोजिट फॉर मीडियल डिस्क बल्ज, मीडियल में आप ट्रैक्शन नहीं देंगे। दिस इज अनदर फिगर फॉर मीडियल डिस्क बल्ज।
Sir,
हाँ जी, you can unmute yourself, you can ask the question.
sir, क्यों नहीं दे सकते ट्रैक्शन मीडियल डिस्क बल्ज में?
अच्छा, इसमें जब हम मीडियल डिस्क बल्ज में देंगे, जब आप स्ट्रेच करते हैं तो द नर्व रूट इज कमिंग नियर टू द स्पाइनल कॉर्ड। जब आप किसी चीज को खींचते हैं, स्ट्रेच आउट होता है ना। जो मीडियल डिस्क बल्ज में क्या होता है, मीडियल जो डिस्क का पार्ट है वो नर्व और स्पाइनल कॉर्ड के बीच में है, स्पाइनल कैनाल और नर्व के बीच में है डिस्क का पार्ट जो बल्ज आउट हुआ है। और जब हम ट्रैक्शन देंगे तो नर्व रूट स्पाइनल कैनाल के नजदीक आता है, खींचता है वो। दैट वुड फर्दर पुट प्रेशर ऑन द डिस्क बल्ज, वो डिस्क बल्ज को और ज्यादा दबाएगा। आप इमेजिन करके देखें, जब हमारा जो पार्ट अंदर है, जैसे ये थर्ड फिगर में है, दिस इज फर्स्ट, दिस इज सेकंड, दिस इज थर्ड। थर्ड फिगर में हमारा डिस्क पार्ट नर्व और स्पाइनल कैनाल के बीच में है। तो जब आप ट्रैक्शन देंगे, स्पाइनल नर्व रूट वुड कम नियर टू द स्पाइनल कैनाल, which would further compress the part of the disc which has bulged out.
ओके सर।
और जब ये डिस्क का पार्ट लेटरल होगा, बिकॉज द नर्व रूट वुड कम नियर टू द स्पाइनल कैनाल विद ट्रैक्शन, तो ये हमारा नर्व जो है वो डिस्क के पार्ट से दूर जाएगा। दैट वुड ईज आउट द प्रेशर ऑन द नर्व। ये लेटरल डिस्क बल्ज में। आर यू एबल टू गेट माय पॉइंट?
यस सर, थैंक यू।
तो जो डिस्क का पार्ट है वो नर्व और स्पाइनल कैनाल के बीच में नहीं होना चाहिए। जो बीच में होता है उसको हम बोलते हैं मीडियल डिस्क बल्ज। उसको हम आइडेंटिफाई कैसे करेंगे? दैट आई हैव ऑलरेडी टोल्ड यू। अगर सियाटिक स्कोलियोसिस उसका अपोजिट साइड है तो लेटरल डिस्क बल्ज है, और अगर उसका सेम साइड है सियाटिक स्कोलियोसिस, या सेम साइड उसको रिलीफ होता है, तो वो मीडियल डिस्क बल्ज है। These are the general precautions while you give traction. Structural diseases or condition affecting the tissues in the area being treated. When severe pain fully resolves with traction. अगर ट्रैक्शन देने से बहुत ज्यादा दर्द एकदम से ठीक हो गया, तो इसका मतलब हमने शायद कुछ प्रिकॉशन है। पेन एकदम से इमीडिएट रिलीफ नहीं होना चाहिए ट्रैक्शन से। अगर पेशेंट डर रहा है, क्लॉस्ट्रोफोबिक है ट्रैक्शन से, इनएबिलिटी टू टॉलरेट प्रोन और सुपाइन पोजीशन, डिसओरिएंटेशन, सर्वाइकल ट्रैक्शन नहीं देना चाहिए जब हमें टेंडोमैंडिबुलर जॉइंट प्रॉब्लम्स हो, टेंचर्स लगे हैं. अगर these are the different parameters we need to take care. स्टैटिक कब देना है, इंटरमिटेंट कब देना है, होल्ड और रिलैक्स का टाइमिंग्स क्या देना है, फोर्स कितना देना है, ड्यूरेशन ऑफ ट्रैक्शन कितना होना है. So this is the table which you can all have a look at. Actually आपको ये सब अभी लिखने का भी जरूरत नहीं होगा, जो आपको पीपीटी आप देख रहे हो आपको प्रोवाइड की जाएगी. इनिशियल फेज में यूजुअली हम स्टैटिक देते हैं. ड्यूरेशन बहुत कम रहता है, यूजुअली 5 मिनट्स, देन स्लोली इंक्रीज till 10 minutes. These are the different indications and goal, and these are the forces that we need to apply. If you want to dig deep on the traction thing, you can study Dutton book by Dutton. These are the parameters for cervical spinal traction. In the flexed position of patient, there is a greater separation of posterior structures. What are the posterior structures? Facet joints and the intervertebral foramen. Neutral or extended position would give greater separation of anterior structures like disc spaces. In the lumbar spine, the body position should be flexion position. It localizes the force to the upper lumbar and lower thoracic spine. Neutral or extension localizes the force to the lower lumbar area. In the cervical spine, the flexed position focuses the forces on the lower cervical area. Neutral or slightly extended position focuses the forces on the upper cervical area. And these are the different articles. Now this is important practical stuff that we would be doing on Wednesday. I would be showing you the cervical and lumbar clicks. Principles of manipulations are strong distraction must be performed before manipulation. This distraction must be maintained throughout the treatment. Joint is rotated during continuing distraction. High velocity thrust must be applied then. Overpressure applied at the end of movement after distraction to perform the thrust. And then we need to re-examine. इसका मतलब क्या है कि मैनिपुलेशन करने से पहले हमें डिस्ट्रैक्शन फोर्स करना है, सेपरेट आउट करना है, and this distraction must be maintained throughout the treatment. Throughout the procedure of manipulation, this distraction force must be maintained. Joint is rotated during continuing distraction, and then high velocity thrust can be applied. So any one of you can please remind me if I forget. This is important, then and we would be showing and doing these techniques on Wednesday. I hope Dr. Niranjan is here and he can maintain the list of important topics that we would be doing on Wednesday.
Sure, sir. No issues.
Okay. And these are the uses of manipulation. It decreases pain, restores range of motion, unlocks the joint, decreases pain through range of motion, systemic hypoalgesia, disruption of articular and periarticular adhesions. These are the different indications, but we must be aware about the contraindications, or which are osteoporosis, hematoma, So in elderly patient, we should be very careful with manipulation. I usually don't give grade 4 thrust in osteoporotic and elderly patient. Nerve root compression, although it is not a contraindication, but sure, cord compression is a contraindication. And we should be careful about rheumatic arthritis, psoriatic arthritis, ankylosing spondylitis. And tumors is definitely a big no. This is the manual distraction. I would be showing you one technique like this for distracting the sacroiliac joint. And the treatment for various soft tissue disorders. For strained muscle, we give transverse friction massage or graded muscle rehabilitation. For strained tendon, we give deep massage. For capsular inflammation, we can go for manipulation. For intra-articular displacement, also we can go for manipulative reduction. For ligamentous sprain, deep massage is preferred, and for tenosynovitis, also deep friction massage is preferred. And this is the article for evidence. These are the general references. Now I would be discussing about the Mulligan's therapy, which is my favorite one. He is the brain Mulligan. Just to give a brief history about him. This is his favorite quote: in the field of scientific discovery,
The
chance
PPT is
only
not
favors
seeing.
the. Okay, you're not able to see my PPT. Okay.
No, sir.
Is it on now?
Yes, sir.
Now visible, sir.
Okay. So he is Brain Mulligan. His favorite quote is in the field of scientific discovery, chance only favors the prepared mind. So whatever we would be discussing on Wednesday or maybe today, this is only a framework. Everyone is open to devise his or her own manual therapy techniques. Okay. So what Brain Mulligans did, he improvised on the Maitland techniques. Like Maitland did the perpendicular direction PA glide on the spinous process. But he improvised and observed then that when we glide on the facet joint in the direction of the treatment plane, that would give a far better results than directly gliding on the spinous process. So that was his observation. So we all are open for our own observations. That way we can develop our own techniques. I would be sharing many of my, I can't say my techniques, but many of my improvisations that I have done and combining different techniques that can be very useful. Okay. Brain Mulligan was trained as a physiotherapist at the New Zealand School of Physiotherapy. He qualified in 1954. And after that, he struggled as a private practitioner in Wellington, where he remained until 2000 when he finally retired from active clinical practice. He was introduced to the field by Stanley Paris in the early 1960s. He acknowledges Freddie Keltenborn as his main mentor, but he also learned from James Cyriax, Jeff Maitland, Robin McKenzie, and Robert Elvey. He formed a small group of physiotherapists, and then he started to give diploma of manipulative therapy. He joined International Lecturing Circuit in 1972. One of his initial students, Barbara took over his diploma program teaching role, and she later became one of his original teachers when the Mulligan Concept Teachers Association was formed. Brain discovered and developed a new field within manual therapy. He initially called it mobilizations with movement. 2 years later, he also discovered pain release phenomena techniques. He has written many books. Many awards has been felicitated upon him. These are the list of awards that he has received. He set up an international organization in 1995 to teach therapists from different countries. Currently, there are 48 Mulligan Concept Teachers Association. So, what is the Mulligan concept? The physiotherapy treatment of musculoskeletal injuries has progressed from its foundation in remedial gymnastics and active exercise. During 1960s or 70s, the physiotherapy was meant to be only remedial gymnastics and active exercise. And now it has improved to therapist applied passive physiological movements and to therapist applied accessory techniques. These are the proposed mechanisms behind Mulligan's mobilization. Mulligan proposed that a minor positional fault of the joint. This is important. Whenever there is a joint, there is a kind of treatment plane in between them. So what he hypothesized was that there is a minor positional fault of one of the bone or one of the segment of the joint, which is giving rise to the problem. Like say in ankle injuries, he hypothesized that when we mobilize tibial end, distal tibial end, posteriorly and superiorly, it can relieve your ankle sprains. So with ankle sprain, there is a positional fault of distal tibial end, which is giving rise to all kind of problems. I would show you that technique on Wednesday. Joint movement can be reduced as a result of reflex muscle splinting, which prevents further damage and reduces nociceptive discharge from the joint by holding it in the mid-range position. It is suggested that treatment directed at the joint will have an effect on muscle activity and vice versa. Joint mobilization and manipulation had a reflex effect on the activity of segmental muscles. Mobilization performed too strongly results in protective muscle spasm. Mulligan's advised that whenever we are doing the nags and different Mulligan's mobilization, it has to be very gentle and steady. It should not be sudden and violent. The combination of joint mobilization with active movement may be responsible for the rapid return of pain-free movement. What the Mulligan was doing is he was giving the gliding as well as he was simultaneously moving the joint. He was asking the patient to move in the comparable movement, and then he was simultaneously giving the glide to the joint. This is called mobilization with movement. This is the underlying treatment principle. Human joint surfaces, they are not fully congruent, as we can see in hip joint, ball and socket joint. And physiological movements occur as a combination of a rotation and a glide. Kaltenborn and Mulligan place particular emphasis on the rotation of the glide component of joint movement to facilitate full pain-free range of movement. Convex concave rule has to be followed. The direction of decreased joint gliding in a hypomobile joint and thus appropriate treatment can be deduced by this rule. I have already explained about the convex concave rule. So Mulligan mobilization also follows this rule. So in a nutshell, the new and unique, this is very unique approach. As the Mulligan mobilization, this is done in weight bearing position. So till now, Maitland was doing the mobilization in a non-weight bearing position, but Mulligan introduced the weight bearing position for the mobilization. Here the mobilization are combined with active or passive physiological movements. Mobilization follow the Kelton-Bond treatment plane rule that applies to both spinal and extremity joints. Mobilizations are sustained at the end of range. So when we gain the gliding at the end of the range, we sustain the glide and we do the overpressure. But overpressure and sustaining of the glide should be pain-free. And this mobilization is applicable to all spinal joints. Allow the therapist to quickly decide if they are indicated or not. So what is the rule for their indication? All the Mulligan mobilization should be pain-free. That is the main indication. So whenever you are mobilizing, whenever you are applying the Mulligan mobilization, that glide should be pain-free. If the glide is not pain-free, we can assume that the gliding was not performed correctly and it was not clinically indicated. And we can get immediate results through Mulligan mobilization. These are the basic protocols of Mulligan's manual therapy. During assessment, the therapist will identify one or more comparable signs. What are the comparable signs? किस रेंज में दर्द हो रहा है, किस डायरेक्शन में दर्द हो रहा है, और स्टिफनेस कितना है. Let's say for on the cervical spine, which side of rotation is more painful? What kind of functional activity is painful? If the patient is complaining कि उसको कंप्यूटर में काम करने से दर्द हो रहा है या उसको करवट में सोने से दर्द हो रहा है. So these are the comparable signs. So these signs can be compared before and after the manual therapy. So these comparable signs can be loss of joint movement, pain associated with movement, pain associated with specific functional activities. That is lateral elbow pain with wrist, resistive wrist flexion, or adverse neural tension. A passive accessory joint mobilization is applied following the principles of Kelton-Bond. These accessory glide must itself be pain-free. So I have already stressed that Mulligan mobilization should always be pain-free. Whenever it is not pain-free, either our technique is not right or the technique is not indicated. And during the performance of manual therapy, Mulligan's manual therapy, the therapist must continuously monitor the patient's reaction to ensure no pain is recreated. The therapist investigates various combinations of parallel or perpendicular glides to find the correct treatment plane and grade of accessory movement. So जब हम Mulligan's की gliding कर रहे हैं, देखो एक brief idea है कि हमारा facet जो joint है उसका जो treatment plane है, from cervical to lumbar it goes from parallel to perpendicular, as I have already explained. लेकिन it can vary from patient to patient and it can vary from vertebra to vertebra. So हमें exact treatment plane लेने के लिए indication क्या है कि gliding हमारी pain free होनी चाहिए. तो उसमें हमें थोड़ा variations करना पड़ सकता है, थोड़ा सा हमें parallel या perpendicular glide देना पड़ सकता है, थोड़ा direction change करना पड़ सकता है. With experience we can master this technique so that our gliding is always pain free. जिस डायरेक्शन में हमारी ग्लाइड पेन फ्री है और हम ज्यादा ग्लाइड कर पा रहे हैं, that is our right gliding. Is everybody able to listen to me? Everyone
Yes.
got my point?
Yes, sir. Yes.
है ना? हर एक पेशेंट के साथ हमें थोड़ा बहुत कस्टमाइज करना है. कस्टमाइज मीन्स हमें ग्लाइडिंग की डायरेक्शन, ग्लाइडिंग का फोर्स हमें चेंज करना है ताकि हमारी जो ग्लाइडिंग है वो पेन फ्री रहे. द रूल इज आवर ग्लाइडिंग शुड बी पेन फ्री. Whenever you are getting a pain, just change your direction a little bit here and there. थोड़ा सा ऊपर नीचे चेंज करके देखो फेसेट प्लेन आपने सही लोकेट किया है या नहीं किया है, उसका डायरेक्शन आपका सही है या नहीं सही है, आपका पेशेंट रिलैक्स्ड है या नहीं है, वो उसका मसल टेंशन तो नहीं आ रहा है बीच में. सो आपको मतलब हर चीज आप री एग्जामिन करोगे, थोड़ा सा अपना डायरेक्शन चेंज करोगे, देन यू कैन ग्लाइड. और उस तब जब आपका ग्लाइड पेन फ्री है, वो आपका सही ग्लाइड है, वो आपकी टेक्निक सही है. whenever it is pain free. Okay, so it can vary from patient to patient. 4 पेशेंट हैं, नेक फ्लेक्शन में उनको दर्द है, तो मे बी फॉर वन पेशेंट यू आर ग्लाइडिंग ऑन द C2 facet plane, on the other you can gliding on the C5 facet plane. You have to check which facet joint is painful, which facet joint is restricted. पेशेंट ने अगर आपको सिर्फ फ्लेक्शन में दर्द बताया, यू हैव टू चेक द रोटेशन मूवमेंट, यू हैव टू check the side flexion, you have to check the PP IVMs, PA IVMs, and then you can land to the conclusion कि आपको कौन सा सेगमेंट मोबिलाइज करना है. अगर आपका एक सेगमेंट मोबिलाइज करते हैं और वो पेनफुल है, ट्राई ऑन द अपर और लोअर सेगमेंट. if you are gliding on the C5 C6 facet joint, if it is painful, try on the C4 C5. if it is painful, try on the C6 C7. ठीक है, डिफरेंट सेगमेंट्स भी आप ट्राई करो, डिफरेंट डायरेक्शंस दे के ट्राई करो. फोर्स को हल्का फुल्का बढ़ा घटा सकते हो, लेकिन वो जेंटल रहना चाहिए फोर्स. मतलब स्लाइटली यू कैन इंक्रीज और डिक्रीज द फोर्स. our main target is that our gliding should be pain free. Whenever you achieve the pain free gliding, that is your technique. While sustaining the accessory glide, the patient is requested to perform the comparable sign. The comparable sign should now be significantly improved. So before and after the manual therapy, we have to compare if the patient is functionally better or not. For the initial sessions, once the patient informs you that he is getting better, you stop the session then and there, and you ask the patient to come on the alternate day. Usually, if the problem is not that kind of chronic, if the problem is chronic, the patient is able to tolerate your mobilization, then you can ask the patient to come on the next day as well. Otherwise, you can ask the patient to come on the alternate day. Failure to improve the comparable sign would indicate that the therapist has not found the correct treatment plane, grade of mobilization, spinal segment, or that the technique is not indicated. I want everyone to pay attention here. If there is a failure to improve the comparable sign, या तो हमारा ट्रीटमेंट प्लेन सही नहीं है, ग्रेड्स ऑफ मोबिलाइजेशन सही नहीं है, स्पाइनल सेगमेंट सही नहीं है, या हमारी टेक्निक सही नहीं है. Am I clear?
Yes, sir.
The previously restricted and or painful motion or activity is repeated by the patient while the therapist continues to maintain the appropriate accessory glide. Let's say patient का shoulder flexion painful है, and now you are giving the Mulligan mobilization to the joint. While maintaining the glide, you ask the patient to flex his shoulder. So if your glide is correct, then his movement should be pain-free. And after achieving the pain-free movement, you can apply the overpressure also. Further gains are expected with repetition during a treatment session, particularly when pain-free overpressure is applied. Let's say, for example, हम C1 C2 facet joint को mobilize कर रहे हैं. Patient का right neck rotation is painful. So I am mobilizing on the facet joint of the C1, C2. So when I have achieved the gliding of the facet joint at C1, C2, I would ask the patient to rotate in the painful direction. And when he has rotated in the painful direction, I would maintain the glide, and after the patient has achieved the rotation, I would apply overpressure on the facet joint. Am I clear to everyone? Am I clear?
Yes,
Am I
sir.
making any sense? देखो आप क्या करेंगे, फॉर एग्जाम्पल अगर पेशेंट का राइट नेक रोटेशन पेनफुल है, you have examined and you have come to the conclusion कि C1 C2 facet joint उनका restricted है, so you are gliding the C1 C2. When you achieve the pain free gliding on C1 C2, then you ask the patient to rotate in the painful direction. While rotation, you maintain the glide, and after achieving the rotation range, you would apply overpressure on the C1 C2 to further gain the glide, to further gain the range of movement. Okay, this is very important. Practically जब हम patient पे करेंगे ये सब apply, तो you would see the magic. After couple of repetitions, let's say 3 or 5 repetitions of gliding on the C1 C2, patient का active range of motion वो pain free हो जाता है. So you can achieve then and there. Results जो है उसी time पे मिल जाएंगे आपको. Self-treatment is often possible using MWM principles with sports type adhesive tape and the patient providing the glide component of the MWM and the patient's own effort to produce the active physiological movement. जब आपने पेशेंट को ग्लाइड कर दिया, पेशेंट को इम्प्रूवमेंट आ गया, तो आप पेशेंट का जो जॉइंट है, जो अफेक्टेड जॉइंट है, उस पर आप टेपिंग कर सकते हैं, सो दैट कि उसका जो मेंटेन है, जो हमने अचीव किया है, वो मेंटेन रहे नेक्स्ट विजिट तक. Successful MWM techniques should render the comparable sign painless while significantly improving function during the application of the technique. Sustained improvements are necessary to justify ongoing intervention. So the Mulligan mobilization would always give you improvement if you have chosen the right glide, right direction, right segment, and the pain is always the guide. So whenever we are doing Mulligan mobilization, it should always be pain-free. Treatment plan I have already discussed in previous PPTs, so I can skip that. So during examination, we need to identify and analyze both the movement that precipitated the injury and the functional activities that continue to exacerbate the symptoms. So you have to document what kind of functional activities bring the pain and which movements are more painful. So initially during examination, you document all these things. बिफोर डूइंग मैनुअल थेरेपी आपको पेन स्केल्स पे पेन मेजर करना है, पेशेंट का रिस्पॉन्स लेना है, जो उसका कंपेरेबल साइंस है वो आपको लिखना है, सो दैट यू कैन कंपेयर आफ्टर द डूइंग द मैनुअल थेरेपी. And knowledge of normal anatomy and biomechanics is essential so that abnormalities can be identified. Active and passive physiological movements and accessory glides are performed so that their contribution to the movement dysfunction and symptoms can be analyzed. I hope all of you are expert in this active and passive physiological movements.
Yes, sir.
Okay, so this is the good example. If the patient is having a painful limitation of wrist extension, the passive physiological and accessory components of radiocarpal and midcarpal extension should be assessed as well as the quality of the intercarpal accessory gliding. तो हमारे कार्पल बोन्स दो लाइन में होते हैं, तो हमारा प्रॉक्सिमल कार्पल्स और डिस्टल कार्पल्स और रेडियल कार्पल और मिड कार्पल बोन्स की जो मूवमेंट है वो हमें असेस करनी है इंडिविजुअली, so that we can know which carpal bones we need to move. Taking the Kelton bone convex concave concept into consideration, if the radiocarpal joint is implicated, the PA glide of the proximal row of carpal bones may be restricted. The testing of intercarpal gliding will specifically identify movement abnormalities between the proximal carpal bones and the adjacent radius or triangular fibrocartilage complex. TFC पता है आपको सबको, रेडियल अल्नर के बीच में होता है सॉफ्ट टिश्यू. काफी पेन्स जो हमारे फोर आर्म के पेन्स हैं वो टीएफसी की वजह से and when you are moving the so you have to mobilize this TFC complex. Once the aggravating movement has been identified, an appropriate glide is chosen. The decision to use a weight bearing or non-weight bearing restricted movement will depend on the severity, irritability, and nature of the condition. Usually, for doing Mulligan's mobilization, I choose weight bearing position. Even if the sin level is high, I would choose Snagg's mobilization. If the patient is apprehensive for weight bearing position, पेशेंट को दर्द इतना है कि वो गर्दन संभाल ही नहीं पा रहा है बैठने पे, then maybe I can do the glidings in lying position. Otherwise, most of the time I would choose the patient in weight bearing position. For a recent trauma or high sin, we can perform the technique in non-weight bearing for a patient with tibiofemoral limitation of extension. Once the glide has been chosen, I want all of you to pay attention because these are the basic principles of Mulligan's mobilization. Once the glide has been chosen, it must be sustained throughout the physiological movement until the joint returns to its original starting position. Let's say right neck rotation painful hai. So when I am moving on the C1, C2 facet joint, I would ask the patient to rotate on the right side. And while the patient is rotating on the right side, I would sustain my glide on C1, C2 throughout the movement. Once he achieved the range of right rotation, I would then apply overpressure. And after applying overpressure, I would still sustain the glide till he comes back to the neutral position. Have I made myself clear?
Yes, sir.
Okay, so this is very important that you have to sustain the glide till the end range of movement, and then you apply overpressure, and even after that you have to sustain the glide till the patient comes back to the neutral position. And usually we repeat this process for 3 or 4 times, and then we compare the comparable signs, and if the patient has improved, we stop the manual therapy, and then we can ask him to we can tape the joint, and we can ask him to come back on alternate day or maybe the next day as the case may be. Or if the patient is in the chronic stage and he is very aware, we can teach him self snacks that I would be telling you on Wednesday. But for today you have to mug up this main principle that you have to sustain the glide till the range of motion, then you have to give overpressure. Even after overpressure, you sustain the glide and ask the patient to come to the neutral position. And another important thing is, as the joint moves, the therapist must sustain the pressure, being constantly aware of minor alterations in the treatment plane. So you have to move around along the treatment plane, and there might be minor alterations of the directions that you apply on the joint. The mobilizations performed are always into resistance but without pain. Immediate relief of pain and improvement in range of movement is expected. If this is not achieved, the therapist may try a different glide or a rotation. If a patient has tibiofemoral pain when performing a half squat, this movement involves a combination of flexion, adduction, and medial rotation of the tibia. Medial rotation and flexion may be restricted and painful when tested in non-weight bearing. Performing a MWM at right angles or parallel to the joint line or own active medial rotation and flexion in this non-weight bearing position may achieve greater improvement. एक एग्जांपल है जिसमें हम नॉन वेट बेयरिंग में हम ज्यादा अचीव कर सकते हैं. Usually for tibiofemoral pain when performing a half squat. Half squat means when we are bending on the knee in the closed chain position. We are standing and doing half squat. So in this closed chain position, this involves combination of flexion, adduction, and medial rotation of tibia. We may not be able to achieve medial rotation of tibia if the patient is having high strain in weight bearing position. So in that case, we have to opt for non-weight bearing position. These are the other principles. Sustain the plane free glide. Movement should be repeated 10 times. Usually I repeat it for 3 to 5 times. 10 times it might give muscle soreness. Reassess to see if the movement remains improved without the passive mobilization components. Repeat this set of 10 MWMs 2 to 3 times to ensure prolonged correction of tracking and sufficient afferent input. See the number of repetitions, it is all dependent on joint irritability. So for the couple of initial sessions, the number of repetitions, usually you can keep it within 3 to 5 repetitions. You slowly increase when the joint irritability improves. Taping can also be applied to help maintain joint position and increase proprioceptive awareness. We can also teach the patient to perform their own MWMs. Now we have different techniques of nags, snags. All these techniques I would discuss on Wednesday. Cervical techniques, lumbar, thoracic. Then different limbs, joints, hips, knee, and I would also be doing pain release phenomena. So I would stop on the mulligans at this point because other stuff is practical that we can discuss on Wednesday. Now I am moving to neurodynamics. Is everyone with me? Is on the same page, or you are feeling lost?
No, sir. You can continue.
Okay. Just to give you a brief introduction of neurodynamics.
Sir, PPT is not visible. First, please check.
Okay, okay, thank you. Firstly, I stop this. I was not aware that you are not able to see my PPT. Is this visible now?
Yes,
Yes,
sir.
sir.
Okay. Dr. Alif Breg is considered to be the pioneer in the field of neurodynamics. He is the original founder of adverse neural tension. He was a Swedish neurosurgeon born in 1910 and he died in 2006. So all the works of neurodynamics are based on his works. But my presentation is mainly referred work by Butler and Michael Shetlock. What is neurodynamics? It encompasses the interactions between mechanics and physiology of the nervous system. Neurodynamics is essentially the clinical application of mechanics and physiology of the nervous system as they relate to each other and are integrated with musculoskeletal system. देखो न्यूरोडायनेमिक्स का मेन प्रिंसिपल क्या है कि न्यूरोडायनेमिक मतलब नर्वस सिस्टम एक हमारा कंटिन्यूअस ऑर्गन है. इट स्टार्ट्स फ्रॉम द ब्रेन, स्पाइनल कॉर्ड, और स्पाइनल कॉर्ड से हमारा नर्व रूट्स आते हैं. तो इट इज कंसिडर्ड एज वन ऑर्गन जो हमारी पूरी बॉडी में फैला हुआ है. सो वेन एवर यू आर मूविंग वन ब्रांच, जैसे एक पेड़ है, एक ट्री है, अगर आप एक ब्रांच को मूव करते हो तो साइमल्टेनियसली दूसरी ब्रांचेस भी मूव करती हैं. Are you able to relate?
Yes, sir.
Okay, so neurodynamics में क्या है कि when I'm moving my wrist into extension, that would move my nerve from wrist till shoulder till neck. उसमें different types की movement होती है, अंदर ही अंदर glidings होती हैं, that we would be discussing. तो जब भी हम कोई एक जॉइंट मूव करते हैं तो वहां की जो नर्व है सिर्फ वहीं पे मूव नहीं कर रही है, इट इज मूविंग टिल इट्स ओरिजिन. एंड मे बी वी कैन सी लेटर ऑन दैट अपोजिट साइड पे भी इम्पैक्ट आता है. जब हम राइट साइड की राइट हैंड की नर्व्स मूव कर रहे हैं तो हमारा लेफ्ट साइड का भी इम्पैक्ट आता है. और वी कैन वेरी वेल सी कि जब हम नेक को कॉन्ट्रालेटरल फ्लेक्शन कर देते हैं तो दैट वुड गिव मोर टेंशन ऑन द opposite side of nerves. So the basic principle of neurodynamics is that the nervous system is a continuous organ. The general layout of the system is mechanical interface, which is defined as that tissue or material adjacent to the nervous system that can move independently to the system. नर्व के आसपास के जो टिश्यूज हैं और जो मटेरियल है वो हमारा मैकेनिकल इंटरफेस है. जैसे नर्व्स डिफरेंट टनल से आती हैं, डिफरेंट लिगामेंट्स के थ्रू आती हैं, डिफरेंट मसल्स के थ्रू आती हैं. तो दैट क्रिएट काइंड ऑफ ए मैकेनिकल इंटरफेस. कार्पल टनल, क्वाइटल टनल, रेडियल टनल, पिरिफॉर्मिस मसल, ये हम अवेयर हैं कि इनके पिरिफॉर्मिस के टाइट होने से शैटिक नर्व कंप्रेशन आ जाता है. आर यू गेटिंग माय पॉइंट?
Yes, sir.
Okay, so the definition of mechanical interface is tissues most anatomically adjacent to the nervous system that can move independently to the system. Pathology at the mechanical interface can give rise to abnormalities in the nerve movement and can cause increase in tension within the nerve. मैकेनिकल इंटरफेस की जो पैथोलॉजी है वो आपके नर्व पे भी इम्पैक्ट कर सकता है, नर्व पे भी प्रॉब्लम क्रिएट कर सकता है. तो अगर हमारा टेनिस एल्बो में हम यूजुअली क्या मानते हैं कि हमारा जो एक्सटेंसर टेंडन्स हैं वो खिंच गए हैं, वो रप्चर हो गए हैं. लेटरल एपिकॉन्डाइलजिया में हम क्या मानते हैं कि एक्सटेंसर डिजिटोरम ब्रेविस खिंच गई है. सो न्यूरोडायनेमिक्स क्या मानती है कि इट इज नॉट ओनली अबाउट द मसल व्हिच हैज बीन अफेक्टेड, हमारा न्यूरल टिश्यू भी अफेक्टेड हो सकता है. इंट्रोशियस नर्व जो वहां से पास ऑन होती है, रेडियल नर्व की ब्रांच जो पास ऑन होती है वो भी अफेक्ट हो सकती है. सो वी नीड टू चेक ऑन द मूवमेंट ऑफ दैट नर्व ऑल्सो कि उसकी इलास्टिसिटी प्लास्टिसिटी उस नर्व की अफेक्ट तो नहीं हुई है ड्यू टू द पैथोलॉजी ऑफ द मैकेनिकल इंटरफेस ओवर देयर. So this neurodynamics teaches us to examine the neural tissue and to rehabilitate that neural tissue and to mobilize that neural tissue. जनरल लेआउट सिस्टम में पहला हमारा मैकेनिकल इंटरफेस है, नेक्स्ट हमारा न्यूरल स्ट्रक्चर्स है, थर्ड हमारा इनोवेटिव टिश्यूज है. The first is that they provide the basis for some causal mechanisms that therapists should pay particular attention. The second reason is for making specific reference to the innovative tissues is that they provide the therapist with the opportunity to move nerves. The third reason is for the treatment basis. So this is neurodynamics. This is the interaction of mechanics and physiology going behind any problem. So the pathomechanics and pathophysiology is interlinked and giving rise to pathodynamics. Just to give you a brief idea of the function, anatomy and physiology, I won't go much deeper into these things. The central nervous system is a dynamic organ like muscle, joint, or any other involved in movement. This nervous system possesses plastic and elastic properties, mechanically and physiologically continuous. So we need to remember that this is a continuous organ. Nervous system जैसे radial या ulnar nerve isolated नहीं है, ये continuous organ है हमारा. Just to give you an idea of the transaction of a nerve, these are the sites of peripheral nerve vulnerability. किस किस साइट्स पे नर्व हमारी अफेक्ट हो सकती है, ये हमें अवेयर होना है. Different tunnels है, like already told you, carpal tunnel, tarsal tunnel. There is also cubital tunnel, radial tunnel. Different branches है nerve की, medial and plantar and lateral plantar nerves. Hard interface है, radial nerve in spiral groove. जैसे रेडियल शाफ्ट का फ्रैक्चर होता है तो many of the cases they develop wrist drop, तो उसमें हमारा रेडियल इंजरी भी हो जाता है. रेडियल रिस्ट ड्रॉप बड़ा एपरेंट है, लेकिन कुछ केसेस में सिर्फ हमें नम्बनेस होता है हाथों में. इवन इफ देयर इज नो रिस्ट ड्रॉप, यू कैन सी नम्बनेस एंड स्लाइट काइंड ऑफ sensation reduction after having injury of shaft of femur or maybe shaft of radius, shaft of humerus, sorry, not femur. तो जब हमारा shaft of humerus पे इंजरी होता है तो that can also injure our radial nerve. So this nerve testing is very important. Proximity to surface where nerves are fixed to interfacing surface, common peroneal nerve at fibula. These are the stages of nerve injury: hypoxia, edema, fibrosis. What happens after nerve injury? First, there is interneural fibrosis, alterations in conduction, loss of elasticity, mechanosensitivity. Loss of elasticity means कि उसकी movement restricted हो जाएगी या painful हो जाएगी movement nerve की. Mechanosensitivity means कि distorted sensations होगा, paresthesia या numbness, tingling. These are the mechanical responses to any nerve injury. Neural movement can be hampered, tension, interneural pressure changes, alterations in cross-sectional shape. Usually, our nervous system, it can stand 18% to 22% of elongation before it starts to get conduction loss, although it varies from patient to patient. Okay, जो हम usually क्या है, हम tension word use नहीं करते हैं, न्यूरोलॉजिकल टेंशन टेस्ट यूज नहीं करते, हम न्यूरोडायनामिक टेस्टिंग टेस्ट यूज करते हैं। न्यूरोडायनामिक टेस्ट टेंशन यूज नहीं करते बिकॉज it makes us think of tightness in the nervous system. Benefits of clinical neurodynamics: it is safer, less stretching of nerves, links diagnosis and treatment to causal mechanisms, integrates neural aspects with musculoskeletal systematic. ये सब डिटेल्ड थ्योरेटिकल चीजें हैं। There are two types of sliding of nerves, longitudinal and transverse. Longitudinal sliding, the sliding of nerves down the tension gradient enables them to lend their tissue towards the part at which elongation is initiated. Longitudinal sliding होता है कि लेंथ में वो लंबी हो सकती है नर्व, और ट्रांसवर्स स्लाइडिंग होता है कि वो ब्रेथ में चौड़ी हो सकती है नर्व. So there is two sliding movement of nerves. One is longitudinal and another is transverse. As we see in carpal tunnel syndrome, our median nerve is affected. It is affected longitudinally as well as transverse. So जब आप न्यूरल टेंशन टेस्ट करते हो तो अल्नर डिविएशन या रेडियल डिविएशन इसका भी नर्व पे अलग अलग रिस्पॉन्स रहता है. It is not only about the wrist extension or elbow extension. It is also about medial ulnar deviation or radial deviation. So there is a movement of transverse gliding as well as longitudinal gliding. Longitudinal sliding prevents excessive tension. Transverse sliding occurs in two ways. The first is to enable the nerve to take the shortest course between 2 points when tension is applied. The second means by sideway pressure by neighboring structures such as muscles and tendon. Sliding of peripheral nerve in the nerve bed is provided by mesoneurome and internal sliding of the fascicles. Transverse sliding prevents excessive compression. मीडियन नर्व हमारी रिस्ट पे 1 to 5 mm तक स्लाइड हो सकती है ट्रांसवर्सली. Neural structures can change their shape when pressure is exerted on them. A clinical example of ulnar nerve in elbow flexion. The epineurum is the padding of the nerve and it protects the axons from excessive compression. It contains finer and less densely packed connective, which gives them spongy qualities and enables the nerve to spring back when pressure is removed. एक तो नर्व हमारी ट्रांसवर्स स्लाइडिंग हो सकती है, लॉन्गिट्यूडनल स्लाइडिंग हो सकती है, और वो कंप्रेशन भी हो सकती है, कंप्रेस हो सकती है. जैसे स्प्रिंग होता है वो हमारा स्प्रिंग कंप्रेस भी हो सकता है और इलोंगेट भी हो सकता है. उसी तरीके से नर्व हमारी कंप्रेस भी हो सकती है. सो इट इज ए मल्टी डायरेक्शनल इलास्टिक स्ट्रक्चर. There are three ways to move nerves. First, just give me a minute, my battery is running short. Okay. There are three ways to move nerves. First, they move the joint. Force direction is away from the joint, different from direction of movement. These are the different movement. These are the how nerves move. Movement of joint. Convergence. The nerves moves in the direction of the joint because that is where elongation is initiated. The effect of two ends produce little or no movement of the nerve relative to the joint, roughly at the midpoint. So convergence means there is a point of the nerve where there is no movement. Whenever you are moving on joint, elbow को हमने flex किया है, so there is a point at the ulnar nerve which is not getting stretched. उस point पे कोई भी movement नहीं हो रही है, क्योंकि there is a two-way sliding. एक हमारा distal sliding हो रहा है ulnar nerve का, एक हमारा proximal sliding हो रहा है ulnar nerve पे. So there is a point where there is no sliding. This is called convergence. Nerves move toward the joint at which tension is being applied. Then we have nerve bending. The bending of the neural structure around the interface is a good example of the combining of fundamental events to produce a more complex action. Ulnar nerve at elbow. In addition to the longitudinal forces being applied to the nervous system from adjacent to the nerve, the innervated tissues can be used to produce such events. As we know, our nervous system is a continuous organ. So dorsiflexion of foot and toes, they are used to apply tension on sciatic nerve. Now briefly we would discuss the neuropathodynamics. देखो ये वाली जो पीपीटी ये बड़ी बोरिंग होने वाली है, लेकिन थोड़ा सा आप अटेंशन पे कर लो. Concepts of neurodynamics by Shacklock. As I've already told, we have three-part system: mechanical interface, neural structures, and innervated tissues. Mechanical interface involves nerve bed and consists of anything that resides next to the nervous system, such as tendon, muscle, bone, intervertebral disc, ligaments, fascia, and blood vessels. Neural structures, these are simply those that constitutes the nervous system. Included are the brain, cranial nerves, spinal cord, nerve rootlets, nerve roots, peripheral nerves. The primary mechanical functions in the nerves are tension, movement, and compression. And the key physiological functions are intraneural blood flow, impulse conduction, axonal transport, inflammation, and mechanosensitivity. Okay. Innervated tissues are simply any tissues that are innervated by the nervous system. So we have a three-part system. First is the mechanical interface, then we have neural structures, then we have innervated tissues. The other concept of neuropathodynamics is tensioner and slider. In the later part, I would be discussing what is tensioner and what is slider. The joints are a key site at which the nerves are elongated. The perineum is the primary guardian against excessive tension and is effectively the cabling in the peripheral nerve. It allows peripheral nerves to withstand approximately 18 to 22% strain before failure. So हमारी जो nerves है वो roughly 20% elongate हो सकती है before they start to get loss of conduction. Sliding, the movement of the neural structures relative to their adjacent tissues. This is called exertion or sliding and occurs in the nerves longitudinally and transversely. As we have already discussed, excursion is an essential aspect of neural function because it serves to dissipate tension in the nervous system. तो nerve की जो elasticity है, movement है, longitudinally, transversely, and compression. This is utmost important because it serves to dissipate tension in the nervous system. So we have two techniques, one is sliders and tensioners. The purpose of slider technique is to provide sliding movement in the neural structures adjacent to the other tissue. So by sliders, we milk away any inflammatory exudate and we remove the we decrease the inflammation around the nerves, because through the sliding movement, we increase the intraneural blood flow of nerves. They produce significant movement in nerves without generating much tension or compression. more useful in the reduction of pain and improving excursion of the nerves. Tensioners produces increased tension in the neural structures, relies on natural viscoelasticity of the neural structures and doesn't pass the elastic limit of the neural tissue. So while applying tensioners, we need to be careful that we don't cross the elastic limit of the neural tissues. We always need to compare to the opposite side before attempting for tensioners. If performed gently, can improve viscoelastic property and physiological function of the neural tissue. Tensioners are used to activate viscoelastic, movement-related, and physiological functions in the nervous system. Two types of sliding I have already discussed: longitudinal and transverse. Compression we have already done. Conversions we have done. Nerve bending I have discussed this briefly, but let me explain it to you. Whenever we have a bending of nerve, let's say when ulnar nerve is bending at the elbow, the same convex and concave rule applied here. Nerve bending induces rise in neural tension by two mechanisms. During tension, nerve chooses shortest route to maintain the internal pressure so that pain is not evoked. Structures around the nerve get compressed by surrounding structures, that is nerve bed. The third is by increase in tension in the nerve producing approximation of its fascicles. Fourth, by the nerve being on the convex side of the joints makes it take a longer course. जो एक नर्व एक किसी जॉइंट पे जहां से बेंड होती है, तो नर्व का जो सेगमेंट कॉन्वेक्स है उसको थोड़ा सा लॉन्गर कोर्स लेना पड़ता है अराउंड द जॉइंट देन इफ इट वर ऑन द कॉन्वेक्स कॉन्केव साइड. जो कॉन्केव साइड है वो शॉर्टर हो जाता है, कॉन्वेक्स साइड लॉन्गर हो जाता है. तो नर्व हैज टू बी दैट काइंड ऑफ इलास्टिक एंड it has to be good plasticity and elasticity so that it can dissipate tension on the concave side and the convex side. Concave हमारा shrink हो जाता है, convex side में हमारा longer route हो जाता है. And fifth, the bending of the nerve produces more tension in the part of nerve that is furthest from the joint axis. Hence, even within the nerve, different part undergo different events depending on the local intricacies. मतलब मेन नटशेल मेन पॉइंट ये है कि एक ही नर्व के अंदर डिफरेंट पार्ट डिफरेंट मूव करते हैं. Nerve bending, during the nerve bending, the convex surface of the nerve that takes longer route than the concave surface of the nerve. The innervated tissues can be used to produce such events. For instance, in the lower limb, dorsiflexion of the foot and toes can be used to apply tension to the sciatic nerve, as this movement is combined with the straight leg raise or slump test. हमारे जो इनर्वेटिव स्ट्रक्चर्स हैं उनकी मूवमेंट की वजह से भी नर्व पे डिफरेंट इफेक्ट्स आते हैं. Now we have two phenomenon, one is closing and one is opening. So the movement of the mechanical interface, जो हमारा मैकेनिकल इंटरफेस है उसका क्लोजिंग फिनोमेना भी हो सकता है. The movement of the closing reduces the distance between the neural tissues and movement complex, and therefore causes pressure to be exerted on the nervous system. Closing phenomena कैसे है? जैसे हम फैलन टेस्ट कर रहे हैं, लेट्स से कार्पल टनल सिंड्रोम्स में हम फैलन टेस्ट करते हैं, तो जो मीडियन नर्व का नर्व बेड है that comes close to the median nerve, which give rise to the symptoms. So if the patient is having carpal tunnel syndrome, we are testing it by a Phelan's test, जो वो हमारा close phenomena है nerve bed के लिए, because the distance between the nerve bed and the median nerve that reduces and it gives more pressure on the median nerve. So the closing maneuvers are useful in diagnosis of an interface component to neural problems. So now we have opening maneuvers. This occurs in the direction away from the nervous system, and therefore produces a Reduction in the pressure on the neural elements. Opening mechanism reduce the pressure on the neural structures by increasing the space around the nerves. Just for the definition, closing mechanisms are those that produce increased pressure on a neural structure by way of reducing the space around it. So a clinical example of using a closing mechanism is Fallon test that I've just explained. Definition of opening mechanisms: these are those that produce reduced pressure on a neural structure. The reduced pressure occurs when the space around the neural structure is increased by a particular maneuver. जब हमारा कोई मूवमेंट किसी नर्व पे से प्रेशर रिलीज करता है, that is called as opening mechanism. Let's say हमारा जो contralateral neck flexion है, when the patient is having a pain at the right trapezius, let's say right trapezius पे pain है, if we give contralateral neck flexion, then the spasm of trapezius can be eased out, which give rise to reduced pressure on the nerves. So this is an example of opening mechanism. Opening occurs in the direction away from the nervous system and therefore produces a reduction in the pressure on the neural elements. Just to give you example in the spine for mechanical interface, neural and innervated tissues. During flexion and extension, mechanical interface is spinal canal. Flexion of the whole spine causes elongation of the spinal neural structures because canal is located behind the axis of rotation of the spinal segments. Tension and strain are the two responses for flexion. जब हम फ्लेक्स कर रहे हैं स्पाइन को, जो न्यूरल टिश्यूज हैं वो हमारे टेंशन में आते हैं. The amount of tension is not clearly known, but strain from lumbar extension to flexion in lumbar dura can reach 30% sacral nerve roots. Dura पे 30% होता है, sacral nerve roots पे 16% होता है. यूजुअली हमारा जो न्यूरल टिश्यूज है वो 20% तक सस्टेन करता है. So when you are moving from extension to flexion, there is a increase in pressure, about 30% increase in pressure on the lumbar dura. Okay, flexion extension में sliding और convergence भी होते हैं. Sliding of the neural structure is complex in spine and specific consequences of movement their own sliding. For example, in neck flexion produces cephalid sliding of neural structure in the lumbar region. Cephalic और caudal. Cephalic मतलब towards the head, caudal मतलब towards the tailbone. ठीक है. तो फॉर एग्जांपल जब हम नेक को फ्लेक्स कर रहे हैं तो जो हमारा न्यूरल स्ट्रक्चर्स में स्लाइडिंग होता है वो टुवर्ड्स द हेड होता है इन द लंबर रीजन. हमारी कमर में जो नर्व्स की स्लाइडिंग होगी दैट वुड बी इन द डायरेक्शन टुवर्ड्स द हेड, बिकॉज हमने नेक को मूव किया है. नेक को फ्लेक्शन में करने से हमारा जो नर्व टिश्यू है इन द लंबर रीजन दैट गेट स्लाइड्स टुवर्ड्स द सिफेलिक हेड की तरफ. और अपोजिट मतलब अपोजिट एग्जांपल है जब हम एसएलआर कर रहे हैं, स्ट्रेट लेग रेज कर रहे हैं, तो लंबर ए रीजन पर हमारा टुवर्ड्स द टेल बोन कॉर्डेड स्लाइडिंग होता है. आई होप नो वन हैज स्लेप्ट. कोई सो तो नहीं गया?
No, sir, but so boring.
मतलब एक्चुअली ये इंपॉर्टेंट कॉन्सेप्ट है. तो व्हेनेवर वी आर डूइंग फ्लेक्स स्पाइन और एक्सटेंशन, तो हमें ये पता होना चाहिए कि कौन सा जॉइंट हमारा मूव कर रहा है, तो हमारा नर्व किस डायरेक्शन में स्लाइड कर रहा है. So when you are
Yes,
moving neck into flexion, we know that our neural structures at lumbar region, they are moving into the towards the head. So when you are doing SLR, our neural structures are moving towards the tail. So for lateral flexion and lateral glide, Mechanical interface is the key event with lateral flexion in relation to mechanical interface is that the intervertebral foramen closed down ipsilateral side and open on the contralateral side. जब हम लेटरल फ्लेक्शन कर रहे हैं, लेट से मैं राइट साइड को लेटरल स्पाइनल फ्लेक्शन कर रहा हूँ, तो जो मेरा राइट साइड के जो नर्वस न्यूरल टिश्यूज हैं वो दे कम क्लोज टू द मैकेनिकल इंटरफेस, और जो मेरे कॉन्ट्रालेटरल साइड, जो मेरा लेफ्ट साइड के नर्व टिश्यू हैं, दे ओपन विद देयर मैकेनिकल इंटरफेस. मतलब नर्व टिश्यू और मैकेनिकल इंटरफेस के बीच में जो डिस्टेंस है वो बढ़ता है ऑन द अपोजिट साइड ऑफ लेटरल फ्लेक्शन. Neural effects. Lateral flexion produces increased tension in the neural structures on the convex side of the spine and reduced tension on the concave side. Concave side, जब मैं right side पे कर रहा हूँ तो concave side कौन सा हुआ? Right side. Convex side कौन सा हुआ? Left side. Left side में मेरे neural structures पे tension बढ़ रहा है, right side पे घट रहा है, क्योंकि left side पे opening हो रही है, right side पे closing हो रही है. Are you on the same page?
Yes, sir.
मुझे लग रहा है सिर्फ
Sir, repeat.
एक ही स्टूडेंट है क्लास में.
सर रिपीट कर दीजिए इसको.
हाँ, एक्चुअली देखो ओपनिंग और क्लोजिंग फिनोमिना क्या है कि जब हम लेटरल फ्लेक्शन कर रहे हैं, लेट से मैं राइट साइड को लेटरल फ्लेक्स कर रहा हूँ, तो जो मेरा राइट साइड के जो न्यूरल टिश्यूज हैं और उनके मैकेनिकल इंटरफेस क्या है, इसमें स्पाइनल कैनाल है. स्पाइनल कैनाल और न्यूरल टिश्यूज के बीच में जो डिस्टेंस है वो कम होता है ऑन द राइट साइड व्हेन आई एम डूइंग राइट साइड फ्लेक्शन, तो उनमें क्लोजिंग फिनोमिना हो रहा है.
यस सर.
तो हमारा जो राइट साइड की नर्व टिश्यूज हैं वो स्ट्रेस्ड हो रही हैं, और व्हेन आई एम डूइंग और उसका जो कॉन्ट्रालेटरल साइड है वहां पे ओपनिंग हो रही है नर्व टिश्यूज का.
यस सर.
ओके,
तो वहाँ पर
देखो
टेंशन
एक
कम
बार
होगा.
दो बार आपको ये
सर वहाँ
पीपीटीज
पर
पढ़नी
टेंशन,
पड़ेंगी.
वहाँ टेंशन
हम्म.
कम होगा ना सर अपोजिट साइड.
हाँ, कॉन्ट्रालेटरल साइड कम हो रहा है, इप्सिलेटरल साइड बढ़ रहा है.
ओके सर.
Increase in tension occurs in two ways. The first is that lateral flexion itself produces elongation of the interface and neural tissues on the convex side. The second is by causing an increase in distance between the spine and the periphery by sideways translation of the vertebra. तो एक्चुअली जब हम न्यूरोडायनामिक टेस्ट करते हैं तो आफ्टर अचीविंग ऑल द सेगमेंट्स, ऑल द मूवमेंट्स, हम साइड फ्लेक्शन भी ऐड कर सकते हैं जस्ट टू सेंसिटाइज द मैन्यूवर. और स्ट्रक्चरल डिफरेंशिएशन करने के लिए हम राइट साइड फ्लेक्शन या लेफ्ट साइड फ्लेक्शन कर सकते हैं. Just to correct myself, the key event with lateral flexion in relation to mechanical interface is that intervertebral foramen close down ipsilateral and open on the contralateral side. ओपन फिनोमिना क्या होता है कि नर्व टिश्यू पे प्रेशर कम हो रहा है. क्लोज डाउन क्या होता है कि नर्व टिश्यू पे प्रेशर बढ़ रहा है.
यस सर.
So we have three types of dysfunctions what Shacklock has identified: mechanical interface dysfunctions, neural dysfunctions, and innervated tissue dysfunctions. So mechanical interface dysfunctions are listed as closing dysfunctions, which can be reduced or excessive; opening dysfunctions, again reduced or excessive; and pathoanatomical dysfunctions like spondylolisthesis, malignancy, or pathophysiological dysfunction like inflammation. Symptoms of reduced closing are symptoms increase with closing movements. So we should be knowing what are the closing movements. Closing का मतलब क्या है कि स्पाइनल कैनाल और नर्व टिश्यू के बीच में जब डिस्टेंस कम हो रहा है, दैट इज अ क्लोजिंग मूवमेंट. In acute and severe dysfunctions, a protective deformity is frequently apparent. This deformity is always in the opening direction so as to reduce the pressure in the adjacent neural structure. जैसे हमारा पोस्चर हम बना लेते हैं, हम ओपनिंग डायरेक्शन में बनाते हैं ताकि हमारी नर्व्स पे प्रेशर कम हो जाए. जैसे फॉरवर्ड नेक पोस्चर है, ताकि हमारा जो एडजेसेंट न्यूरल टिश्यू पे प्रेशर कम हो जाए. एक्सटेंशन पोस्चर क्या होता है? एक्सटेंशन पे नर्व पे प्रेशर बढ़ता है, फ्लेक्शन पे जो हमारा न्यूरल टिश्यू है, एडजेसेंट न्यूरल टिश्यू है, उस पे प्रेशर कम होता है, तो हमारा फॉरवर्ड नेक पोस्चर हो जाता है. हैव यू सीन फॉरवर्ड नेक पोस्चर इन नेक पेन?
Yes, sir. Mostly.
और एक सर्वाइकल हम्प बन जाता है और पेशेंट का नेक, शोल्डर्स ड्रूप हो जाते हैं, नेक थोड़ा सा बेंडिंग डायरेक्शन में होता है और थोरैक्स में काइफोसिस थोड़ा सा बढ़ जाता है. These are the common presentation of patient with neck pain. In excessive closing maneuver, the symptoms are provoked by closing mechanisms. Hypermobility, instability, or habitual closing exist. History would be habitual posture or posture imperfection is common. Sometimes a history of trauma and features of instability. In the reduced opening dysfunction, the symptoms are usually aches and pains in the localized area with or without referred pain. Opening movements provoke pain and are usually restricted. There is usually history of trauma in which patient has been forced into opening positions. The body then compensates during healing process by causing inflammation and muscular spasm such that opening movements are reduced to avoid further provocation.
सर ये ओपनिंग मूवमेंट्स पेन को कैसे प्रोवोक करेंगे?
ये ओपनिंग डिस्फंक्शन का रिड्यूस्ड ओपनिंग है. जो रिड्यूस्ड ओपनिंग मतलब है कि उस एरिया में ओपनिंग हम कुछ भी करेंगे, ओपनिंग मूवमेंट हम जो भी करेंगे वो पेन को प्रोवोक करेगा.
ओके,
ठीक है. तो जो उसमें यूजुअली सिम्टम्स क्या है? aches and pains in the localized area with or without referred pain.
ठीक है सर.
किसी भी ट्रॉमा हो गया या जैसे चोट लग गई तो पेशेंट हैज बीन फोर्स्ड इनटू ओपनिंग पोजीशन. तो थर्स्टफुली पेशेंट ओपनिंग पोजीशन में आ गया है, नर्व बेड पे देयर इज ए एक्सेस ऑफ इंट्रान्यूरल ब्लड फ्लो. तो नर्व बेड ऑलरेडी हमारा स्टेन्ड पोजीशन में है, तो अगर हम उसको फर्दर ओपनिंग मूवमेंट में करते हैं तो उसमें नर्व प्रेशर बढ़ता है.
ओके ओके, ठीक है.
The reduced opening dysfunction produces a protective spasm on the ipsilateral side, unlike closing type has on contralateral side. Closing dysfunction में contralateral side पे protective spasm होता है, reduced dysfunction में ipsilateral side पे protective spasm होता है. See, this kind of dysfunction, opening dysfunction or closed dysfunction, ये आपको 2 बार 3 बार पढ़ना पड़ेगा to get a good understanding of it. My main target for these 2 days is that you get a good hands on. तो ये जो मैं PPTs आपको शेयर करूंगा ये आप 1 बार 2 बार पढ़ लेंगे आगे के 2 दिनों में, so that on Wednesday we are prepared for practical thing, है ना. हमारा जो मेन अचीवमेंट है, मेन गोल है, हमारा हैंड्स ऑन स्किल अच्छा होना चाहिए. पेशेंट को मतलब है कि उसको रिजल्ट मिलना चाहिए.
डेफिनेटली
तो हम वेडनेसडे को सीखेंगे कि हाउ वी आर इंटीग्रेटिंग न्यूरोडायनेमिक अप्रोच विद मुलिगन्स, है ना. हम मुलिगन्स की ग्लाइडिंग भी दे रहे हैं, साथ में हम न्यूरोडायनेमिक टेक्निक भी कर रहे हैं और किस तरीके से फिर हम नर्व की इलास्टिसिटी बढ़ा रहे हैं अलोंग विद मुलिगन टेक्निक्स. तो बेसिकली हमारा टारगेट वो है कि उस चीज को हमें अचीव करना है। ये जो हमारी थ्योरेटिकल है, ये आपको डिसाइड करने में हेल्प करेगा कि कौन सी टेक्निक्स आपको यूज करनी है। मतलब टेक्निक्स हमने मगअप नहीं करनी है, हम अपनी खुद की
Yes, sir.
टेक्निक्स डिवाइस कर सकते हैं इफ वी हैव ए अंडरस्टैंडिंग ऑफ दिस थ्योरेटिकल एस्पेक्ट।
Yes, sir.
The symptoms of excessive opening are aches and pains and can produce referred pain, pins and needles, numbness. Symptoms are intermittent and they are produced when provoking movements occur. Usually there is no deformity, opening movements are increased, and that is eventually leading to this disorder. Example is cervical contralateral flexion and rotation. Tenderness over specific areas is often present. Hypermobility produces mechanical irritation of the relevant structures. So now I'm coming to the neural dysfunction. We have neural sliding dysfunction, neural tension dysfunction, and hypermobility. The aims of neural mobilization is to reconstruct normal neuromechanical condition, that is adapting the nervous system to constantly changing loads and mechanical tension. जैसे यूजुअली स्पोर्ट्स में क्या होता है, जिम्नास्टिक्स में क्या होता है, दे हैव ए ग्रेट बैलेंस, क्योंकि उनका नर्वस सिस्टम अडेप्ट कर चुका है डिफरेंट मूवमेंट्स पे, कॉम्बिनेशन ऑफ मूवमेंट्स पे. द पर्सन हु इज सेडेंटरी, हु इज नॉट ट्रेन्ड, he is far less physical active than the person who is constantly repeatedly doing different kind of sports activity. हमारे मूवमेंट करने से, डिफरेंट एक्टिविटीज करने से हमारा नर्वस सिस्टम डिफरेंट हो जाता है. सो आवर नर्वस सिस्टम रिमेन मोबाइल एंड इलास्टिक इफ वी आर डूइंग सम काइंड ऑफ स्पोर्ट्स एक्टिविटी. तो जो हम पैसिव न्यूरल मोबिलाइजेशन करते हैं, दैट इज आल्सो एम टू अचीव न्यूरल मोबिलिटी. ओके, तो जो स्पोर्ट्स में लोग होते हैं, जो जिम्नास्ट करते हैं, दे हैव ए वेरी गुड बैलेंस ऑफ न्यूरल सिस्टम. उनका जो नर्वस सिस्टम का इलास्टिसिटी होता है वो बहुत बढ़िया होता है ड्यू टू द रिपीटेड ट्रेनिंग एंड एक्सरसाइज. Neural mobilization involves stretching and pulling nerve trunks, spinal roots, spinal nerves, spinal cord, and spinal meninges by effecting movements of joint in a precisely isolated positions. So, what is the stage that we should start neural mobilization? It should be started earliest possible stage. Whenever you have patient of wrist drop or maybe numbness, paresthesia, whenever there is a neural symptoms, or even if there is no neural symptoms, you have trapezius spasm, you should check the neural system if it is completely normal or not. In most of the cases, even in muscle spasm, you would find that there is a slight compromise of neural tissue. So we should be able to mobilize that neural tissue in the earliest possible stage. Neural mobilization should involve the entire length of the nerve trunk. The primary objective in neural mobilization is to improve neuromechanical function through mobilization of peripheral nerves, spinal roots, spinal meninges, and the perineural connective tissue. These neural mobilization techniques restore normal neuromechanical function of both peripheral nerves and the central nervous system. Clinical tests performed in connection with neural mobilization consist of testing of exteroceptive sensation, superficial sensation, 2-point discrimination, and proprioceptive sensation vibrations. Like जैसे हमने बैचलर स्टडी में पढ़ा था, 2-point discrimination, soft touch, hard touch, feather touch. So this is the testing for exteroceptive sensation. Examination of indicator muscle function, innervated mostly by one segment, testing muscle reflexes. DTRs हैं जो different. I hope you must be aware about different muscle reflexes. examination of nerve trunk lesion, examination of nerve trunk mobility. The essential examination conducted before performing neural mobilization involves nerve trunk tension and mobility test. Positive results of these tests include elicitation of a symptomatic pain reaction, differential symptoms in symmetry test performed on the opposite upper limb, confirmation of the symptoms by discriminatory testing of other tissues, confirmation of symptoms by palpation of nerve trunk through irritation. So हम डायग्नोसिस पे कैसे आएंगे? अगर हमारा न्यूरल टेस्ट सिम्टोमेटिक पेन को दोबारा से वापस एलिसिट करता है ना? डिफरेंशियल सिम्टम्स इन सिमेट्री टेस्ट, अगर हमारा अपोजिट साइड पे जो हम टेस्ट करते हैं उसमें सिम्टम्स सेम अगर नहीं होते तो कंफर्मेशन ऑफ सिम्टम्स बाय डिस्क्रिमिनेटरी टेस्टिंग ऑफ अदर टिश्यूज, अगर हम डिफरेंट टिश्यूज इन्वॉल्व करते हैं तो हमारे सिम्टम्स डिफर हो जाते हैं. नर्व पैल्पेशन पे सिम्टम्स अगर एलिसिट होते हैं तो वो कंफर्मेशन है. Tension test consists in stretching a given nerve, spinal cord or meninges by moving joints in areas where these structures are found in such a way as to enable the maximum possible adjustment of the nervous system. The stretching effect is increased by angular placement of the joint and also by joint traction. So in the upcoming PPTs, we will be learning how to test different nerves. A positive test result reflects a lack of elasticity in the conducting structures. Mobility test induces a shift of the nervous system by placing the examined fragment of neural tissue in a rest position. A positive test reveals a limitation in the supporting connective tissue in the nerve or the presence of external compression factors. Positive test enable the test to be used as mobilization technique. ये इंपॉर्टेंट है, जो भी जिस लेवल पे हमें सिम्टम्स एलिसिट हो जाते हैं वो उसको हम एज ए मोबिलाइजेशन टेक्निक यूज कर सकते हैं. इनिशियली वी कैन यूज इट एज ए स्लाइडर, one-way slider, two-way slider, and then slowly we can progress for one-way tensioner and then two-way tensioner. Initially, two series of impulsation procedures of a few second durations are performed at a frequency of 2 to 4 impulsations per second. ये important है. Slowly we can increase the duration. The duration of the procedure is extended to 20 to 30 seconds with increasing amplitude of movement in the joint through which the impulsation, longer duration of a single impulse and more series of impulsations. In chronic condition, between 10 to 60 stretches are performed, lasting up to 20 seconds. So this we can note down as a dosage. Initially, we start with very low dose, 2 to 4 impulsations per second. And then we extend to 20 to 30 seconds with increasing amplitude of movement. In chronic conditions, it is between 10 to 60 stretches are performed, lasting up to 20 seconds. It must be emphasized that this method is based on the principle of painlessness, corresponding with concept of painlessness and opposite motion. Patient should not feel any pain either during or after the procedure. So for neural mobilization, again our main criteria should be that it should be painless. While producing tension of a nerve trunk, the therapist doesn't know which structure has caused the dysfunction. In the course of the procedure, the stretching force is received by the tissue which has lost elasticity. The remaining structures gradually adapt to the progressing tension and rearrangement. तो जो हमारा मेन साइट होगा नर्व टिश्यू का वो लास्ट में इंप्रूव होगा. जो उसका डिस्टल सेगमेंट्स हैं पहले हम डिस्टली मोबिलाइज करेंगे, जहां पे मेन न्यूरल टिश्यू डैमेज है वहां पे हम धीरे धीरे अडेप्ट करेंगे. इन द क्रॉनिक स्टेज वी वुड मोबिलाइज दैट. The contradiction to neural mobilization is acute injuries to the central and peripheral nervous system, tumors, infection, fever, unstable neurological symptoms, or pain at rest. Pain at rest means it is a red flag kind of thing. We have to rule out the other red flags if pain at rest is there. Other contraindications are cauda equina injury symptoms, spinal instability, congenital anomaly of the spinal column, lack of patient compliance. If the patient is not ready, he's not giving consent to you. So how can you do the neural mobilization? Usually in the Western world, India में तो अभी शुरू नहीं हुआ है, लेकिन patient से consent लेना जरूरी है before doing neural mobilization. Has everybody heard what I'm saying?
Yes, sir. Yes, sir.
Yes.
इंडिया में अभी लीगल नहीं है, लेकिन it is always better to get written consent from patient, because
Definitely.
neural mobilization पे when we are starting, when we are new, हम जब beginners होते हैं तो हम बहुत violently या excitement में हम damage भी कर सकते हैं. So it is always better to get written consent. और neural mobilization बहुत slow and steady आपको doses बढ़ाना है, बहुत धीरे धीरे करना है. First you have to start with sliders. Slowly you progress to tensioners. So these are the effect of neural mobilization: pain reduction, improved perfusion, reduced edema, improved axonal transport, reduced sympathetic tone, restoration of normal neuromechanical function, restoration of normal physiological function. Another 7-8 slides are there, then we can maybe wind up the class. Now we are coming to the levels of neurodynamic testing. Shacklock has graded different levels to the neurodynamic testing. We have level 0, level 1, level 2, level 3. Level 3 is divided into A, B, C, and D. So level 0 is where the testing is contraindicated, where patient is a very high sin patient, patient is apprehensive. So we are not doing any neurodynamic testing on level 0. Level 1 is limited examination. Indications are when symptoms are already or are easily provoked and takes long time to settle after movement. The patient is having high sin, but the symptom do ease out after a long time. In cases of severe pain, presence of any neurological deficit, when symptoms show a progressive worsening after physical examination. So all this is level 1. So the components we use in level 1 of neurodynamic testing is different from level 2. Level 1, we start with distal components, remote components. Let's say if the patient is having wrist pain, we suspect some kind of radial injury. So we start with remote components, maybe shoulder abduction, contralateral neck flexion, and we start with the off switch of lateral. We are not adding contralateral neck flexion afterwards. We are adding contralateral neck flexion before adding other distal symptoms. So whenever we have symptoms, elicit of symptoms, we can ask the patient to get his neck into neutral position. That would be off switch for the symptoms. So the patient would be easily symptoms would be easily eliminated. So that is the level 1. You add only the remote components of neurodynamic test. For the level 2, this is the standard examination. Indications are problem is not easily provoked and symptoms are not severe. Neurological impairment is absent when pain is not severe during examination. Contraindications are when there is bony instability, hypersensitivity, or irritability. Level 3 examinations indications are when level 2 testing is normal and did not reveal sufficient information. Symptoms are stable and not easily provoked. When there is no coexisting pathology that might adversely affect the nervous system. Contradiction, it is same as level 2. So the level 3 is divided into A, B, C, D. It depends on the sin level. For A, it is comparatively higher sin than B. So we add remote segments, then gradually we add segment nearer to the symptoms. Let's say for wrist, we add remote segments first, then we gradually add the segments which are near to the wrist. For the 3B, we more aggressively we add wrist symptoms, and then for 3C, we start to add wrist symptoms first, then we add remote segments, remote movement. And for 3D, we do the resisted movement on the wrist. After we achieve all the movement of neural test, we add resisted movement at the wrist. So that is a 3D, which is very low sin. When the patient has nearly improved, and then you add resisted movement, that would put more pressure on the wrist tendons. Let's say in carpal tunnel, that will decrease the joint space between carpal tunnel and median nerve, and that would put more pressure on the median nerve when we do the resisted movement at the wrist. So these are the 3 levels of level 3, A, B, C, and D. In summary, level 0, we don't do any neurodynamic test. Level 1, it is very limited. Level 2 is standard. Level 3 is neurodynamically sensitized. Neurodynamic sequencing is followed. We need to be aware about the sin level in level 3, and we can gradually increase the amplitude of the test in level 3. Multistructural symptomatic position movement. So the general points to be noted is we need to explain to the patient what kind of procedure we are doing. We need to compare it bilaterally, and we start with the unaffected side. Maintain each movement precisely. Be gentle and don't hurry. We just evoke the symptoms. We don't provoke the symptoms. Evoking is just elicit of symptoms and we stop there. And afterwards, you just release one of the symptoms so that the symptoms get ease out. Short duration of testing. You slowly and steadily increase the duration of testing. You start with very short duration. The application of neural mobilization in musculoskeletal condition is effective provided that the patient is properly diagnosed and the pathology is functional. Neural mobilization procedure should be performed in musculoskeletal system diseases on condition that the results of tension and mobility test are positive. Different musculoskeletal condition require different techniques. You would be able to devise your own techniques once you understand the pathology behind these neural tissues. It must be borne in mind that neural mobilization is a component of conservative treatment and should not be used in monotherapy. Monotherapy means it should not be used in isolation, but included in a therapeutic regimen together with other physiotherapeutic procedures and pharmacotherapy. So the neural mobilization का मतलब ये नहीं कि हम सिर्फ neural mobilization कर रहे हैं, इसके साथ साथ हम different mobilizations को मतलब एक holistic approach है जिसमें हम combination of movement कर रहे हैं, combination of therapies कर रहे हैं, neural mobilization भी कर रहे हैं, Mulligan's भी कर रहे हैं, Maitland भी help ले रहे हैं, और साथ के साथ हम फार्माकोथेरेपी मतलब जो रिक्वायर्ड है मेडिसिन का एज पर फिजिशियन वो हम कंटिन्यू कर रहे हैं. These are the different references. That should be all for the day. I have a couple of few PPTs left, which I should be able to cover on Wednesday. Is everybody here or left?
Yes.
I think only
No, sir.
25 participants are there. So
Yes, sir.
7-8 participants have left already.
Yes, sir. We are here.
एक्चुअली क्या है, इसीलिए मैंने ये ऑनलाइन रखा है, क्योंकि अगर फेस टू फेस इतना लंबा मैं करता तो आप लोग क्लास में ही सो जाते। यहाँ कम से कम सो रहे हो तो मुझे दिखाई नहीं दे रही।
नहीं सर, ऐसा कुछ नहीं।
अच्छा, ये न्यूरल मोबिलाइजेशन बहुत इफेक्टिव है और बहुत ही यूजफुल है, मतलब इन क्लिनिकल प्रैक्टिस। इफ एनी वन ऑफ यू वांट्स टू डू क्लिनिकल थिंग ना, तो यू शुड बी प्रोफिशिएंट इन न्यूरल मोबिलाइजेशन एंड स्पेसिफिकली इन दिस न्यूरो डायनामिक टेक्निक्स। अगर आपको हैंड्स ऑन अच्छा आ जाता है, विद प्रैक्टिस यू वुड बी एबल टू गेन दैट।